series on. This time healthcare workers are passing a very tough time. We lost a lot of our colleagues, and many of our teachers and doctors have been suffering from the COVID disease. We pray to Allah for their recovery. And you know that BSCI came forward in this period to do some academic exercise, like to improvise or to inspire our young generation cardiologists, interventional cardiologists, to inspire them. They arrange a interactive case-based discussion series. We are glad to hear that Professor Fazlur Rahman, President BSCI, and Professor Mir Jamal, Secretary General of BSCI, and BSCI Scientific Committee Chairperson, Professor Dr. Fazilatunisa Malik are with us. We have also very learned faculties today with us. Professor Abdullah Shafi Majumdar, Secretary General Bangladesh Cardiac Society, as well as our guide and our Amadir Ovivo, Professor Abdullah Shafi Majumdar sir. Among with us, supposed to be here, he will join soon, Dr. N.A.M. Mominuzzaman. Professor Afzalur Rahman, he will join soon. Professor Abdul Wadud Chaudhary sir already joined. Professor Dr. Mamunur Dr. Kamrul Islam, Professor Mahu Ali sir joined with us. We are very glad to be see him here. Professor Muhammad Shahabuddin Talukdar already joined. Professor Muhammad Athar Ali, Professor M. Maksumul Haq, Professor Abdul Qadir Akundu sir, he will join. Professor Pavit Kumar Das is with us, and also there are Dr. Kaisar Nasrullah Khan already joined. Dr. Shams Monor, Dr. A.Q.M. Reza, and Professor Dr. Colonel Syed Alia Sultana will join soon. There are also Professor Tawfiq Rahman, Professor Amul Kumar Chaudhary, Professor Khandakar Shahid Hussain, Professor M.J. Azam, Professor Mahbub Rahman is with us. We welcome you to today's webinar. Before going to case, I would like to request to give welcome address our Chairperson Scientific Committee, Bangladesh Society of Cardiology, Professor Dr. Fazilatunisa Malik. Madam, would you please give a welcome address to the audience? Madam, unmute, please. Yeah, unmute. Adnan, unmute, madam. Okay.
Yes, I think I'm good now.
Yes, madam can unmute for request participation.
Teachers, friends, colleagues, and students, welcome to this session organized by Bangladesh Society of Coronary Interventions, and this is going to be an interactive case-based session. As Dr. Nur Alam has already emphasized, we are indeed going through very tough times. We have already lost a lot of our loved colleagues, and their loss is irreplaceable. But one good thing we have also seen is that some of our colleagues have made it through. Especially, we are so happy today to have Professor Mir Jamal with us. He is all right, and we have all prayed for all our colleagues, and we hope and pray that none of us get sick. And through these difficult times, getting together like this really is a boost to us, both mentally as well as spiritually. So without further ado, I would like to welcome you all to this session, and it's just like meeting friends again. We have known each other for so many years, some of us 20 years, 30 years, and it's like coming together. So thank you for giving me this opportunity to welcome you all. And without further ado, I would request Nur Alam to start with the proceedings. Thank you.
Thank you, madam. Now may I request our Honorable Secretary General, Professor Mir Jamal sir, to say a few words to the audience regarding today's webinar. Mir Jamal sir. Unmute, sir, please.
Sir, unmute.
Am I unmute? শোনা যাচ্ছে?
Yes, sir.
Yes, sir.
Assalamu alaikum. আজকে আমরা অত্যন্ত আনন্দের বিষয় যে আপনাদের সাথে সায়েন্টিফিক সেমিনারে আবার বসতে পারছি এই কোভিড সিচুয়েশনে সারা পৃথিবী যেখানে স্তব্ধ এবং সেখানে আমরাও স্তব্ধ, তবে এই ওয়েবিনারের মাধ্যমেই সবাই সবার সাথে কমিউনিকেট করতেছে, সব প্রোগ্রামগুলি এখন ওয়েবিনারের মাধ্যমে হইতেছে এবং এই কারণেই আমরাও এইভাবে শুরু করলাম যেন আগামী দিনেও আমরা সায়েন্টিফিক প্রোগ্রাম আমাদের একাডেমিক অ্যাক্টিভিটি কন্টিনিউ করতে পারি। এখানে উপস্থিত আছেন আমার বাংলাদেশ সোসাইটি অফ কার্ডিওভাস্কুলার ইন্টারভেনশনের সভাপতি প্রফেসর এ কে এম ফজলুর রহমান এবং প্রফেসর ফজিলাতুন্নেসা মালিক, যিনি আমাদেরকে অলরেডি তার স্বাগত ভাষণ দিয়েছেন, প্রফেসর আব্দুল্লাহ শাফি মজুমদার, এক্স ডিরেক্টর NICBT and সেক্রেটারি জেনারেল বাংলাদেশ কার্ডিয়াক সোসাইটি। আব্দুল স্যার এখনো জয়েন করেন না, এক্স প্রেসিডেন্ট সোসাইটি অফ বাংলাদেশ কার্ডিওভাস্কুলার ইন্টারভেনশন। মমনুজ্জামান ভাই একটু দেরি হবে জয়েন করতে, উনি বলেছেন আমাদেরকে, উনি আবার ওনার এলাকায় চলে গেছেন, ওখান থেকে হয়তো জয়েন করবেন। প্রফেসর আব্দুল ওয়াদুদ চৌধুরী, হেড অফ দ্য ডিপার্টমেন্ট অফ কার্ডিওলজি, ঢাকা মেডিকেল কলেজ। প্রফেসর মামুনুর রশিদ, প্রফেসর অফ ইন্টারভেনশনাল কার্ডিওলজি, ICBD। প্রফেসর মোহাম্মদ শফিউদ্দিন, প্রফেসর অফ কার্ডিওলজি, BSMMU। প্রফেসর সৈয়দ আলী হাসান, he will also join later, and Dr. Sorabujjaman, head of the department of cardiology, lab 8. Professor Taufikur Rahman, Professor Amol Kumar Chaudhary, professor of cardiology, NICBD. Professor Khandakar Shohid Hussain, professor of cardiology, NICBD. Professor MJ Azam, professor of cardiology, NICBD. Professor Mahabub Ali, my mentor, is ex-professor of cardiology, NICBD. প্রফেসর খন্দকার কামরুল ইসলাম ও অন্যান্য সকল প্যানেলিস্টগণ, আপনাদেরকে আন্তরিক ধন্যবাদ। আপনারা আজকে আমাদের এই সায়েন্টিফিক প্রোগ্রামে সাড়া দিয়ে সবাই একত্র হয়েছেন এবং আমরা এই সায়েন্টিফিক প্রোগ্রাম ইনশাআল্লাহ, এটা হলো সিরিজ 1, ইন্টারঅ্যাক্টিভ টেস্ট বেসড ডিসকাশন সিরিজ 1, আমরা এরপরে কন্টিনিউ করতে থাকবো। এরকম 1, 2, 3, 4 বিভিন্ন সময়ে আমরা আমাদের সায়েন্টিফিক প্রোগ্রামগুলি এবং সায়েন্টিফিক অ্যাক্টিভিটি এভাবে কন্টিনিউ করব। তা না হলে আমাদের ইয়াং কলিগরা যারা এখনো ফিল্ডে কাজ করতেছেন, আমরা বুড়ারা তো অনেকেই কাজ করতে পারতেছি না বা করতেছি না, কিন্তু ইয়াং যারা ফিল্ডে কাজ করছেন তাদের প্রেরণা শক্তি আমাদেরকে যোগাতে হবে এবং তাদের প্রেরণা শক্তির জন্যই আমরা এইভাবে প্রোগ্রাম করে যাব আগামী দিনে, যাতে আমাদের ইয়াংরা আগামী দিনে আরো ডেভেলপ করে এবং আমাদের young generation in the field of interventional cardiology internationally recognized হতে পারে, সেই দিকেই আমরা অগ্রসর হওয়ার জন্য এই প্রোগ্রামগুলি করে যাব। আমার সকল টিচার এবং উপস্থিত যারা আছেন সকলকে আন্তরিক ধন্যবাদ জ্ঞাপন করে আমরা আমাদের অনুষ্ঠানে যাচ্ছি। ধন্যবাদ সকল।
Thank you, sir. Before going to our case presentation, may I request Professor Abdullah Shafi Mumdar, sir, to say few words regarding today's webinar. Abdullah Shafi Majumdar, sir. Professor Abdullah Shafi Majumdar, sir.
Yeah, thank you very much for inviting me to join and to say something. First of all, I just greet my colleagues of the Bangladesh Society of Cardiovascular Intervention, the President Professor Fazlur Rahman and Secretary General Professor Mir Jamal for arranging this conference, and Professor Fazila, who welcome all us. I greet her also, and my regards and respect to all my colleagues and my fellows. And I think this series of interactive sessions will succeed in achieving the goal of training the our younger generation. Thank you very much. Thank you.
Thank you, sir. Thank you. Now may I request our Professor A.K.M. Fazlur Rahman, sir, for giving his presidential address as well as inaugurate the case-based discussion series on. Fazlur Rahman, sir.
শোনা যাচ্ছে তো না? আসসালামু আলাইকুম। আমি আমার বক্তব্যের প্রারম্ভেই আমাদের যে চিকিৎসক এবং অন্যান্য যারা এই কোভিড মহামারীতে মারা গেছেন বা আক্রান্ত হয়েছেন তাদের জন্য তাদের অত্যন্ত শ্রদ্ধা করে স্মরণ করছি। আর আজকের এই সেমিনারে অনেককে দেখে আমার অনেক ভালো লাগছে। আমাদের টিচার, আমাদের স্টুডেন্ট, আমাদের কলিগ, আসলে আমাদের মধ্যে অনেক দিন যাবত দেখা হচ্ছে না, কথাবার্তা বলা হচ্ছে না সরাসরি। এটা একটা অন্যতম একটা মাধ্যম। এই ক্ষেত্রে আজকের এই সেমিনারে বা ওয়েবিনারে উপস্থিত আছেন আমার শ্রদ্ধেয় শিক্ষক, জাতীয় হৃদরোগ প্রতিষ্ঠানের সাবেক ডাইরেক্টর, বাংলাদেশ সোসাইটি অফ বাংলাদেশ কার্ডিয়াক সোসাইটির সম্মানিত সেক্রেটারি জেনারেল। আরো উপস্থিত আছেন আমাদের বাংলাদেশ সোসাইটি অফ কার্ডিওভাস্কুলার ইন্টারভেনশনের সাবেক প্রেসিডেন্ট ডক্টর মমিনুজ্জামান, ডক্টর আফজালুর রহমান, সাবেক সেক্রেটারি জেনারেল অধ্যাপক শাহাবুদ্দিন তালুকদার, প্রফেসর মাহবুব আলী, কায়সার নসরুল্লাহ খান। আরো উপস্থিত আছেন আমাদের শ্রদ্ধেয় ম্যাডাম ফজিলাতুন্নেসা মালিক, আমার সোসাইটির সদস্যবৃন্দ এবং অন্যান্য অডিয়েন্স বৃন্দ, আসসালামু আলাইকুম। আপনারা জানেন যে আমরা গত 19 নভেম্বর 12 তারিখে অত্র সোসাইটির দায়িত্বভার গ্রহণ করার পরে আমরা বিভিন্ন প্রোগ্রাম যেগুলো চেষ্টা করেছিলাম ইনক্লুডিং our academic calendar, our international seminar, our other academic activity and social work, সেগুলো আমরা কোভিড এর কারণে অগ্রসর হতে পারিনি। যদিও কোভিড আমাদের সেই প্রোগ্রামগুলি স্থিমিত করে দিয়েছে, কিন্তু একদম বন্ধ করতে পারেনি। তারই ধারাবাহিকতায় আজকের এই কোভিড এর এই সময়ে বাংলাদেশ কার্ডিওভাস্কুলার সোসাইটির পক্ষ থেকে আমরা জাতীয় পর্যায়ে গাইডলাইন করেছি এবং সেটা জাতীয় পর্যায়ে এবং আন্তর্জাতিক পর্যায়ে অত্যন্ত গৃহীত হয়েছে। আমরা আন্তর্জাতিক এবং জাতীয়ভাবে কয়েকটা ওয়েবিনার করেছি এবং আজকের ধারাবাহিকতায় সেই আরেকটা ওয়েবিনার আমরা শুরু করেছি। আমার সেক্রেটারি জেনারেল বলেছেন যে দেশে যদি এরকম দুর্যোগ থাকে তাহলে তো আমরা বসে থাকতে পারি না। সেই জন্য অত্র সোসাইটির কার্যক্রমকে আমরা ত্বরান্বিত করে অগ্রসর করে নেওয়ার জন্য তারই ধারাবাহিকতা আজকের এই সেমিনার। এখানে অনেকেই উপস্থিত, সবাইকে আমার সোসাইটির পক্ষ থেকে আমি ধন্যবাদ জানাচ্ছি। আরেকটা বিষয় আমি ধন্যবাদ না দিয়ে পারছি না, সেটা হলো জাতীয় গাইডলাইন তৈরি করতে আমার সেক্রেটারি জেনারেল এবং সায়েন্টিফিক সেক্রেটারি যে শ্রম দিয়েছেন এবং সেটা আমাদের সোসাইটিকে ভাবমূর্তি জাতীয় লেভেলে অনেক উন্নতি করেছে। আমার সোসাইটির পক্ষ থেকে আমি ওনাদেরকে ধন্যবাদ জ্ঞাপন করছি। আমি আর দেরি করতে চাচ্ছি না, যদিও এটা একটা একাডেমিক অনুষ্ঠান, কিন্তু যেহেতু সুযোগ হয় না, তাই সোসাইটির কিছু জিনিস সবাইকে অবহিত করা আমার প্রয়োজন বলে আমি এই বক্তব্য দিয়েছি। আমি ডক্টর নুর আলমকে রিকোয়েস্ট করব, আপনি অনুষ্ঠান ইনশাআল্লাহ শুরু করে দেন। আমাদের সায়েন্টিফিক সেমিনার you can start now. Thank you very much.
Thank you, sir, for your inspiring speech. We are seeing Professor Afzalur Rahman, sir. We are very happy to see you, sir. Professor Mohammad Maksumul Haq, sir, is here. Professor Atar Ali, sir, is joined with us. Dr. Mohsin Ahmed Bhai joined with us. Dr. Shahabuddin, sir, joined with us. We are very happy to see you, sir. Now we will go to our case presentation. We have 6 presenters. For every presenter will present 7 minutes, and after that 5 minutes discussion. And now may I request our first presenter, Dr. Saqib Shahriar from NICVD. He will talk on something happens unexpectedly during coronary intervention. Dr. Saqib Shahriar, you please share your screen.
Respected chairpersons and all our teachers and panelists and some of our teachers of our teachers, very good evening to all. First of all, I must congratulate and say my gratitude to BSCI for arranging such a nice academic program for discussion, so that we can learn from our teachers and we can learn our mistakes also. Today I shall be talking on something happens unexpectedly during coronary intervention. I have no potential conflict of interest. My first case, 55 years old gentleman, hypertensive diabetic, having chest pain for last 1 month and gradually worsening in nature. The ECG shows inferior ischemia and echo revealed ejection fraction 48%. His coronary angiogram done in another hospital. He came to NSABD for PCI. And this is angiogram shows in the left system there is a lesion in the OM1 branch, and in the mid part of the RCA is 100% occluded. So in a coronary angiogram, we have found significant lesion in the OM lesion and RCA 100% stenosis in the mid part. Then we planned to proceed PCI to RCA first, and transradial approach is our default approach. We put a run-through guide wire and part into the distal RCA, and pre-dilation done by 2 into 15 mm semi-compliant balloon. During stent placement in the RCA, we have observed there is a aortic sinus dissection and with extending into the sinus. Then it is a horrible condition, and we have to look for his hemodynamic status, ECG, and clinical signs symptoms also. Then the second case, I was with my colleague. My colleague is doing this angiogram in the very early morning at 8 a.m. And he is 70 years old man, hypertensive diabetic, non-STMI patient. And this is the first shot on the right side. After giving the dye, we seen that there is a dissection in the aortic sinus, which is extending retrogradely into the sinus, and RCA is narrow caliber disease. Then we become anxious and a bit because it is the first case. Our seniors are not present at that. And then I called my senior colleagues and also my professors, and also called the cardiac surgeons, and look for the status, clinical status and signs symptoms of the patients. And we took the left system of the also, and doing his completed his angiogram, which showed significant lesion in the proximal LAD. So what to do next in this situation? How to proceed for? Should we go for conservative management or send the patient for surgery or interventional procedure? In the first procedure, in the first patient, we first check his hemodynamic status, and his hemodynamic status is BP is suddenly slightly dropped and sudden ECG changes. So we plan for urgent. Our aim was to close the dissection part, not to extend the dissection further. So we are planned first we go for PCI to RC in the mid part, 3 into 25 millimeter drug-eluting stent. Then we took another stent which overlapping the first stent and extending, which covering the ostium as well as in the sinus. Some of the part of the stent is extending and hanging within the sinus, and we put the stent successfully. It is 3 into 25 millimeter drug-eluting stents. Then after the stenting, we observe his hemodynamic condition is stable, and after 20 minutes of the dissection, we observed that it is gradually sealed. So we sent the patient to post-CAD and post-CAD ward and CCU. We observed his clinical status, ECG changes, cardiac biomarkers, and bedside echo also. But bedside echo showed there is no. In the second case, as the patient, we thought that it is an old patient, so we are anxious. But the patient did not showed any clinical signs symptoms, no chest pain also. And he also even did not agree to lie in his bed also. because he told that his angiogram is already done. So we took our seniors' decision as well as the cardiac surgeon decision and managed conservatively. After 30 minutes, the shadow is gradually decreasing, and we also managed him conservatively. We sent the patient to post-cath ward, and after the procedure, thoracic ecography shows no extension of the dissection and also no AR. And on the subsequent day, we checked the aortic CT aortography, which does not show any significant dissection, and cardiac biomarkers was also normal. And in the first case, on the third day, we took the patient to a CT angiogram room, and we checked the CT aortography, which also revealed no significant extension of the dissection. So both the patient's hospital course were uneventful. They were discharged the fourth day on the hospital stay, and well and asymptomatic at the 4-week follow-up also. This is the classification of the aortic coronary dissection. It is a Dunning classification. In class 1, contrast extending involving only the coronary sinus of the valsalva, and in class 2, it is within the aortic sinus but not extending more than 4 centimeter. In class 3, it is contrast extending up to the more than 40 centimeter up to the arch of aorta and ascending aorta also. In class 1, class 2, we can go for conservative approach and also sometimes PCI. But in class 3, we have to go for surgery. So my take-home message is incidence of iatrogenic aortocoronary dissection are around 0.6 to 0.1% of the PCI and 0.06% for during coronary angiography. And this can occur due to trauma caused by the tip of the diagnostic guiding catheter and subintimal entry of a stiff guide wire or due to excessive balloon dilation. The majority of the aortic dissection occurred during PCI to RCA and results from mechanical trauma due to hardware manipulation is important. So localized dissection can be treated by ostial placement of a stent or conservative management. Thank you for your patience hearing, and I must pay my respect to my professor, Dr. Mir Jamaluddin sir, who has already cured from the battling from the COVID situation, and all of my team members. And I must pay my respect to all of the teachers hearing and all the participants here. Thank you all.
Thank you, Sakib, for showing us a nice case. May I request Professor Fazila Madam? Fazila Madam, are you here? Professor Fazila Madam? If she was here.
I'm here, yes.
Madam, would you please comment on Sakib case regarding coronary dissection, either spontaneous or iatrogenic, and how he managed? Would you please comment?
So congratulations on managing 2 very difficult cases and for treating them well. You happen to be my students, so it's
thank you, Madam.
See you grow and evolve and do angiograms and all independently and PCI. Well done, and you have a great mentor in Professor Mir Jamal, who's going to guide you well, and the whole crowd in NICVD. So this is a learning, and we all are learning. So what did you learn? What do you think happened? Do you think it was that your catheter in the second case was not coaxial or something? Or did you, I mean, most of the cases, complications may occur due to iatrogenic reasons, right? So what do you feel was, what is your opinion, that it was catheter induced or what?
Yeah, Sakib can mute current. Sakib can mute current.
Can you hear me?
Yes, we can.
Thank you, Fazila Malik Madam. She is my teacher. Thank you for the appreciation. In the second case, Madam, in diagnostic angiography, most often we very often it found the dissection like that. But I haven't found this type of dissection, though I am very junior and young. But I think sometimes in radial in transradial approach, we have to engage both left and right system by the same Tiger catheter. Sometimes we have to be very cautious because only finger movements should be done, not vigorous movement, and we have to careful also. And RC engagement is easy in a transradial approach. Sometimes it hooked very abruptly or vigorously into the sinus. I think there may be there could be aux catheter, or it was handled by abruptly so that it can hook into the aortic, into the ostium, and it hits. And sometimes it also enters into the conus artery also, and deep engagement also. So catheter induced dissection can be done, and we most often it is found in most commonly in the right RC ostium, because there may be anatomical variation of the ostium of the RC also. But in the first case, I think the catheter is not coaxial properly, and there may be after the predilation of the mid RC lesion, when we pull back the balloon, according to the law, it pushes the ostium. There may be the cause of the decision, I think, madam.
So whatever reason, the main lesson I think that we learn from your case is that we need to manage it. In some cases, we need to do it conservatively, and in some cases, we need to be active like you were in the first case. So congratulations on a case well done. And Noor Alam, I'm very sorry, I actually have to leave. This is such a fascinating session, and I would have loved to be here all the time, but this is a personal family commitment that I was committed to go to. So I apologize, but it was great seeing you all, and inshallah, we'll be here again in the next session. So I would like to say Allah Hafiz to all of you, and see you again. And then so continue. I'm really regretting that I'm going to miss all the cases, but at least I got to see a very interesting first case. Thank you so much, and continue with the session. Thank you.
Thank you, madam. May we took another comment from Maksumul Haq sir, from Professor Maksumul Haq sir. He is a radial operator. Do you think that this dissection he managed the way this is right, or anything could be done, or how cautious should be needed to an operator to avoid dissection?
Thank you, everybody. Assalamu alaikum. I am very happy to join this webinar arranged by the organization, and congratulations to Dr. Sharia for presenting two very nice and not a very common feature. And I have encountered one or two cases in my life, and this is a dreadful situation. The first reaction is panic, which everybody faces, but he remained cool and tackled this situation very nicely. And it happens in right coronary artery, and I think the sudden entry into the right coronary ostium when you rotate to engage, this may be one of the cause, because you don't have any, especially the second case, you don't have any control the first engagement. So what I personally do after engagement, I just give a small injection, not a forceful injection, to see that my catheter is properly placed. I don't inject very vigorously, both in the left and right system, because this is one of the cause of, I think, dissection if you inadvertently give forceful injection without seeing where the catheter is. And another, I think important issue is post management, which he has done nicely, but you have to keep the blood pressure and pulse as far low as possible, so that the dissection does not extend. This is also important. And one of the reason maybe that the case I had, she had spontaneous bleeding tendency. Even she had conjunctival bleeding, a lady. So some of the patients may have a increased bleeding tendency. Small trauma may cause bleeding. Anyway, nice case, nice, very good 2 cases, and nicely managed. Thank you very much.
Thank you, thank you, sir, for your nice comment. Now we'll proceed to our second presenter, Dr. Anisul Awal, Assistant Professor, Chattogram Medical College, Chattogram. He will show us again a radial route. His topic is a scary journey through the radial route. Dr. Anisul Awal, can you hear us? Yes, we can see your screen. Unmute Anisul Awal. Anisul Awal, can you hear us? We can see you can see your screen. Anisul Awal, Dr. Anisul Awal, can you hear us?
Yes, sir. Slideshow mode जाओ. Slideshow.
আনিস তোমার হেডফোনটা খুলে কথা বলো তাহলে হয়তো
Please
কাজ হবে
unmute yourself.
Dr.
কথা
Anis,
চলে যাচ্ছে না তোমার হেডফোনটা খুলে হয়তো কথা বললে কথা শুনে যেতে পারে ডিসকানেক্ট করো
এখানে তো থাকে এই যে এটা
Dr. Anis, can you hear us? Please off your screen share. Please off your screen share, then re-entry.
ওকে একটু ফোন দাও না ওকে একটা ফোন দাও আদনান
Yes, sir, sir.
আদনান ফোন দাও ওকে
Sir, আমি স্যার ফোন দিচ্ছি স্যার
আমার মনে হয় ওকে সুযোগ দিয়ে থার্ড ওয়ানকে ই করে স্টার্ট করলে সে আর পরের বার আসুক সেকেন্ড কেসটা থার্ডে চলে যায়
Anisul bhai, hai. Anisul bhai, can you hear us?
Hello, yeah.
হ্যাঁ আপনি শুনতে পাচ্ছি হ্যাঁ আপনি শুরু করেন আনিস ভাই শুরু করেন পাওয়ারপয়েন্ট মোডে যান
স্ক্রিন শেয়ার করতে হচ্ছে না যে
হ্যাঁ আনিস ভাই আপনাকে আমরা দেখতে পাচ্ছি শুনতে পাচ্ছি ভেরি লাউড এন্ড ক্লিয়ার
ওকে দেন
আনিস মোডে যাও স্লাইড শো মোডে যাও
ওকে ওকে
Go to PowerPoint mode, PowerPoint, slideshow.
Yeah.
Dr. Anis, go to slideshow mode and click there and then move your slide. First we cancel your zoom. There is an icon or there is something in your screen. Cancel it or okay it.
নুরালো প্রয়োজন হলে তুমি তৃতীয় কেসটা শুরু করো ও রেডি হোক তারপরে আসো
আনিস তুমি কম্পিউটার বন্ধ করো অন
স্ক্রিন শেয়ার প্লিজ অফ ইউর স্ক্রিন শেয়ার
আনিস আপনি রিস্টার্ট করেন হ্যাঁ আমার মনে হয় আপনি রিস্টার্ট করেন ততক্ষণে আমরা থার্ড কেসটা
Okay, there is some technical difficulties from Anisul's side. We will hear from him.
Can you
later.
hear me now?
Yes, we are hearing. We are very loud and clear. You
okay,
just
then I'm starting.
You just okay. Okay. Cancel it. Okay. Then go.
Yeah.
Yes.
Okay.
Yes. Click and move. Okay. You start.
Okay, sorry for the technical difficulty. Assalamu alaikum and very good evening. It's my great pleasure to be a part of this great initiative by Bangladesh Society of Cardiac Intervention. And I will talk on a scary journey through radial route. Indeed, this is a great night because I can see many of my favorite teachers and mentors here. This is a rare opportunity. Even when we present in Dhaka, different occasions, not we can get all together. So my first case, this is a story of a 67-year-old housewife. She was hypertensive, non-diabetic, and she had a history of better life. And she was actually had antiseptal 1 year back and thrombolized with streptokinase on that time. This time she was presented with non-ST elevation MI and chest pain, and she was treated with the low molecular heparin. So we took her to the cath lab and we did the angio. We found this double vessel disease. As you can appreciate, LAD have two significant lesion in proximal and mid LAD, and also there is a lesion in the RCA. And we planned to do the RCA lesion first, and everything was going fine. Heparinized, and JR 3.5 6 French was taken, Ramthroy was taken, and we dilate the lesion 2x10 balloon, and Ramthroy where was every time was going to conus branch, we keep the branch there, and we put another Ramthroy in the distally and take out the wire in the conus branch. Then pre-dilate 2x10 balloon. Then we put a drug-eluting stent 3/18, 3.518, and post-dilate the lesion. So everything was going fine. Patient was doing fine, and only I had a little feeling of tight feeling while I was moving the catheter. That's the only thing. After finishing this, we then plan to do the left side by EVO catheter. But while taking out the catheter JR, patient was complaining of bit pain. And while we tried to introduce the EVO catheter, there was it is not crossing, and we found there is a scary perforation. Immediately we try to cross a PTC wire, but failed. And you see the patient is heparinized. We put one stent, and we are pending another stent, and this is scary perforation thing happens. So we again gently try to put a PTC wire, but not able to do it. So then we postponed, and catheter withdrawn. Intermittent inflation of the forearm at mean pressure for 5 to 6 hours, like 15 minutes we keep inflated, and another 10 or 15 minutes deflated. In this way, we did it. And however, with this maneuver, she was settled, and in the next day, we took her again the cath lab. But this time, we afraid to go through the radial route again. So this time, we choose the femoral route, and this time we didn't want to make any mistake. Under fluoro, with puncture, single puncture, anterior puncture, and we cross a Ramthroy wire. And we did pre-dilatation, and with the 2x10 balloon, and we take a stent 3/35 drug-eluting sirolimus stent, or zero was taken, and we post-dilate with the 3.5x10, and we optimize the port by. So as you can appreciate the final result. So those started with the scary situation, but we end with the happy thing. I want to show another case where there is a balloon stuck. This is not a very common thing. This is the story of a tribal woman. She was 62 years. She had diabetes. She has tobacco intake in the form of betel leaf, and she presented to us with acute inferior MI. We thrombolized her, and her echo shows wall motion abnormality. Ejection fraction was 55%. And 10 hours back, she was presented, and we did this angiogram, and we found the left system is fine, and her right system, we had a 2 lesion in the mid and the distal part of the RCA. So we take a JR 3.5, and we run through where. So everything was going very nicely. We put a stand distally, 2.75x10 stand, and we optimized by checking the stand boost. Everything fine. We took a from proximal lesion, and there was also non-significant lesion proximal. We took a bit larger stand, and we put that stand also. We deployed the stand without any difficulties. But when we started to use a big stand, when it started to post dilate from distal part, then the problem started. And balloon was not balloon stuck. It's not deflating, and we try to inflate and deflate several times, and we try to saline flush, and we take with the 50 cc syringe. Nothing is really working. And we did, as the lesion was in the balloon is in the distal part, we are not there to put a hard wire of the hard end of the wire to puncture it. So patient gradually is sinking, and we just without make any delay, we put a TPM, and also we started CPR. We called the ICU doctor. They came, and we started CPR and intubate. Then we just whole thing gently we pull back, and you see what happened. There is like concertina-like effect, but after CPR and all this, you see the final slide. The stent is okay, but patient was sent to the ICU. This is how the patient is managed. So this is my end of this presentation. Intervention accompanying the complication. Radial artery perforation is an uncommon complication during PCI, but potentially lead to acute compartmental syndrome and limb ischemia. So prompt recognition and treatment is warranted. And undeflatable balloon during PCI is a rare complication, but potentially life-threatening, needs immediate bailout. Complication during PCI may appear at any time, at any stage, like tsunami. Perseverance, teamwork, cool-headedness, and anticipatory preparedness is key to overcome it. So in this COVID era, we want the gloomy weather to go out. We want to be all these outdoor activities. Inshallah, we'll be able to this. This is why. Thank you. Thank you very much for your patient hearing.
Thank you, Dr. Anisul Awal, for your nice case. Would you please off your screen share so that we can see our faculties? Please off your screen share.
Okay. Yeah.
Thank you. Thank you. So we have seen a case. May I request Professor Atar Ali sir, would you please comment on Dr. Anisul Awal case? Sir, please unmute, sir. Please unmute, sir. Yes, sir.
So thank you very much for nice presentation. I would happy if there were arrhythmia, but luckily there is no arrhythmia. But still, thank you very much for nice two cases presentation. I want to know from Dr. Anisul Awal, actually, how did you manage the radial perforation? Just inflation and deflation, or did you any pressure compression for the how many times? That is how many days or something there? As because he did another procedure on the next day, that is the same. Repeat the procedure on the next day, and you did the more heparin. So how did you manage? I think it was a big perforation in the radial artery. So what was the actual outcome of this radial artery perforation? How did you manage it?
Thank you very much, sir. Actually, we had the opportunity. We tried to do the as the heparin is already patient just heparinized, and we had another lesion left. And patient, I did the case in the private center, and patient had the economic constraint. She wanted to have in the same package at least 3 days. So we had wanted to do the same thing in the same day by putting a PTCA wire. If we are able to cross the lesion, we could have a with the guide catheter there will be a sealing effect. But as we are unable to do that, so we started to doing. We had another option. We can go through femoral route. We can put a balloon and inflate it like that. But we started the conservative. We just blood pressure cuff. I talked with the Mir Jaman sir, and I had seen his cases in Dhaka how he managed it. The sir also assured me that you go ahead with this procedure, you may be able to do it. You may not have any problem. Maybe the next day you can do the second case. So I exactly did what sir said. I started inflation for 15 minutes and leave it for another 10-15 minutes, and I put a pulse oximeter on his hand and to check that everything is going fine. And I keep the pressure. His pressure was around 115. I keep his heart pressure was 100, and I had done it like 5 to 6 hours. In book it says the 5-6 times may be good enough. Even in 2 or 3 times, if not working well, you're supposed to refer the patient to the vascular surgeon. So vascular surgeon is not readily available in Chittagong. That's why we started conservatively. As patient was doing fine, we are keep on monitoring. And the next day, as if there's all swelling, pain, all gone away. And there is some ecchymosis that also gone away. So we had the courage that we can do it. And fortunately, we are able to do that. And patient discharged without any difficulties. And patient is still in our follow-up. She's fine now.
Thank you very much. I'm happy with the answer. Thank you.
Dr. Ashok Datta is here. He is a radial operator. If he has any comment, Dr. Ashok Datta. Can you hear me, Dr. Ashok Datta? Please unmute, Dr. Ashok Datta.
Please.
Yeah.
Yes.
Yeah, you can. Yes.
Yeah. Thank you. It's a both cases are good, Dr. Anis. Congratulations. And the other thing that is very important, not to get panic. already Maqful Haq sir mentioned it, and you have consulted with your senior, Mir Jamal sir. That is another good thing that you did. Anyhow, it is better to do the procedure on the next day, because there was a big hematoma, so that usually takes a bit longer time. And whenever such a big hematoma happens, next day giving heparin another 10,000 may produce further oozing from the site. So anyhow, you have managed the case very efficiently. Definitively, you deserve congratulations. Thank you.
Thank you, Dr. Ashok Datto, for your nice comment. May we proceed our third case. Third case will be presented by Dr. Nazmul Laila. She is from National Heart Foundation Hospital and Research Institute. She will talk on left main bifurcation lesion tackled with T and protrusion tap technique. Dr. Nazmul Laila, left main bifurcation lesion tackled with tap technique. You can see your screen. Okay, just go ahead. Okay.
Can you hear me?
Yes, clear and audible.
Assalamu alaikum, distinguished chairpersons, respected moderators, my seniors, teachers, colleagues, assalamu alaikum. It's indeed a privilege and an honor to be able to present on such an eminent podium today. I'm Dr. Nazmul Laila. I work at the National Heart Foundation Hospital and Research Institute. Before I go to my presentation, just a bit of a background on our hospital. It is a non-government, non-private organization. It is developed under the public-private partnership. We have a 480-bedded tertiary care cardiac hospital, fully equipped with modern tools, and we are at present providing modern cardiac care at an affordable price. We began our cath lab journey in the year 1999, and since then it has been a promising and a very productive journey. In the year 2019, we've covered 15,084 cases. The number of total procedures we've done so far are 170,000, and the numbers of total PCI is more than 40,870. The case I'll be presenting today is a live case transmission from our hospital at AIC 2012. The operator was our head of department, Professor Dr. Fazilatunisa Malik, and it was carried out from our hospital. The patient then was a male 45-year-old. He was hypertensive, diabetic, and a regular smoker. He was previously diagnosed as a non-ST elevation MI, but he has a good, his left ventricular ejection fraction was preserved. On angiogram, you can appreciate that the left main coronary artery had an 80 to 90% stenosis involving the origins of both left anterior descending and the left circumflex. The left circumflex was a dominant vessel with the 95 to 99% stenosis at the origin. Left anterior descending had a long diffuse disease with a stenosis of 80 to 95% in its proximal part starting from the origin. So on calculating the syntax score of 32, our heart team was consulted and involving the patient and his attendants, and we decided to proceed with the PCI. Left main to left anterior descending and left circumflex, both the vessels were wired with a floppy wire. Pre-dilatation was done. Pre-dilatation was done with a 2.5 by 15 millimeter non-compliant balloon in left main to circumflex. This is the picture after pre-dilatation. A drug-eluting stent measuring 4.0 by 26 millimeter was deployed in left main to circumflex. Subsequently, the left anterior descending artery was rewired through the stent strut, and pre-dilatation was done in left anterior descending lower down with its diagonal with a 2.0 by 15 millimeter balloon. This was the view after pre-dilatation. Subsequently, a drug-eluting stent measuring 2.75 by 30 millimeters was deployed at mid-LAD. With respect to doing the TAP technique, as customary of the TAP technique, a 3.5 by 24 millimeter drug-eluting stent was placed in left anterior descending, and a 3.5 by 10 millimeter non-compliant balloon was placed in left main to circumflex. After stem deployment in the left anterior descending involving its origin, kissing balloon dilatation was done with the same balloons at 12 atmospheres. This was the view showing a reasonable TME3 flow after stenting. On IVA's study, it was seen that the bifurcation, sorry, I can't. I'm sorry. Well, the IVAS showed that the bifurcation angle was quite good, but proximal left main had still some disease and was underdilated. So a report was done with a 4.5 by 18 millimeters non-compliant balloon, and this was the final result. So in summary, proper assessment of the left main lesion and strategizing the procedure is very important. During distal left main PCI, placing guide wires in both the branches is recommended. Proper lesion preparation with sequential non-compliant balloons or debulking devices is mandatory. New generation drug-eluting stent should always be used, and proper sizing of the stent is also very important. Optimal post-dilatation is absolutely mandatory. As in double stent techniques, spinal kissing is also very important. But proximal optimization as well as report should always be performed when required. In many instances, intravascular ultrasound is an invaluable tool to optimize procedural results in left main intervention. As we believe at National Heart Foundation Hospital, as we believe in the best results are attained with teamwork from the team of National Heart Foundation Hospital and Research Institute. Thank you.
Thank you, Dr. Nazmul Laila, for your brilliant presentation. Left main bifurcation. Could you please offer? Okay, thank you. So left main bifurcation, we approach with a TAP technique. So now I will invite discussion regarding what are the possibilities. Is it a case for decay crash or anything else? So Dr. Adnan, would you please open the mode of self-unmutation? If anybody can discuss, he can unmute himself. Dr. Adnan.
Okay, sir. Okay, sir. I will do that.
So now I request our chairpersons or panelists or faculty, see if anybody want to comment or any question regarding this or suggestion, he will unmute and ask question.
Okay. I have one question.
We'll take Afzal sir's comment, then I will take question.
Oh, sorry. Sorry for interruption. This is a very nice and brilliant case, I think so. This is a complex left main distal bifurcation. Definitely, this case has to be done by upfront two stent strategies. That is, from the initial, we have to go for two stent strategies. And as the LCX is the dominant vessel, that's why they put that LCX is the main vessel. They tackle the LCX first, then think that the LAD is the side branches. This is the standard. I think so. This is a very nice demonstration. And then they finished it by TAP technique. But definitely you can do the decay crash, definitely. But TAP is the most easiest way to do the double stent strategy. And outcome is not bad because decay crash is a little bit complex. And for recrossing, sometimes is a problem. But in TAP technique, you will not face any problem for the recrossing. And this is the case you can do the TAP technique. Other thing is that after putting the first stent, I'm sure that has been post dilatation. So after putting because we size the stent according to the size of the distal vessels. That's why in the left main there should be some gap after putting the stent. So it must be first port is very important. I'm sure this is done as a first port, though in the demonstration it was not indicated, but I'm sure that it is first port was done. And then otherwise, what happened that if you don't do the first port, there is a gap between the proximal stent start and the left main. So your wire maybe goes down in between the gap and come back to the stent, and then you can be this may be the disaster for the patient. I think so. I'm sure that it has been done like that, and then they recross it and final kissing and whatever the comment sheet elegantly presented is absolutely fine. You have to finish by post dilation, and in this situation, I think so. IVAS is a mandatory and maybe the better outcome. If you do a provisional single stent strategy, even left main, you may not have an IVAS, but if you have to do the double stent strategy, you must do the IVAS. Otherwise, you should not do it. So thank you for patient nice case, and thank you BSCI for arranging such kind of interesting session. And thank you everybody.
Thank you, sir. Mir Jamal sir, would like to add something? Mir Jamal sir.
Thank you. Already Professor Abdul sir has told it's a difficult case. Distal left main, meaning that bifurcation left main is always difficult case, and it is complex case. And here it is from very beginning, performer decided to have double stent strategy. And in double stent strategy, sir has already told that tap technique is most easier and safer also. And final port or report, what has been done, that should be, the balloon should be smaller in length so that it does not interfere the distal edge of any stent. And so far, I think the balloon was smaller, but she told 4 into 18. Left main may not be 4 into 18. Left main may be 4 into 12 or 4 into 8 or 10, 12, this maybe. Probably she has mentioned the length of the balloon mistakenly 4 into 18. It may be smaller, and it should be smaller and wider. Thank you for your excellent case and excellently done. Thank you.
Nurullam sir. Hello.
Yeah, yes.
I have.
Hello.
May I just.
Yes. Dr. Ashok.
Yes, sir. Mir Jamal sir, as, how are you, sir? Just.
Sir,
actually, yeah. Thank you, sir. Thank you, Abdul sir, for your comment. Actually, report and report, Mir Jamal sir already told that small balloon, short length balloon.
Short length.
First, yeah, that is very important. If you don't have short length balloon in your cath lab, better not to do that decay crash or something like this.
Yes.
But as the ostium of the left main is already been stented, then a bit longer balloon, 12 or 18, it may be hanged into the outer. So
yes,
report.
that is possible. That is possible.
So possibly she did the same thing by putting the part of the balloon
inside the outer.
After that, the report was done because finally she ended with report. So definitive report was done before.
Of course, Sir has very nicely mentioned that if we do not do port initially, then your wire may be behind the start, and that will be miracle.
Exactly, sir.
Thank you, sir. Thank you, Dr. Mohsin Ahmed. Would you want to comment?
Thank you, Nurulam. Nice case demonstration. First thing, before operator doing, they start the bifurcation lesion. What is the angle of the lesion? So this lesion is around near the 90-degree angle. So it should be tap or tapping is the best choice of an angle of the lesion. So we nicely done tap, and if angle is near to the 45-degree, then we go for the crash or mini crash or decay crash. One thing is, in case of bifurcation lesion, should not do sitting. You should next day sitting, because you can have the everywhere size of the balloon, small balloon and aggregate diameter. So thank you BSCI for arranging the nice session. Thank you.
Thank you. Dr. Shahabuddin Talukdar sir, would you please want to comment?
Nolam bhai. Dr. Mahbub.
Dr. Mahbub, you have question. Ask your question.
Thank you BSCI for this nice presentation. I am
Please
Dr.
open your
Mahbub
camera.
Rahman.
Camera, please. Open your camera.
Camera is not working.
Okay.
Here the lesson is 0 Medina Medina 0. Hello.
Sir, we are coming to you, sir. Shahabuddin sir, we are coming to you. Just we're taking a question, sir.
I think. Hello. The lesson is 011 Medina.
Yes.
And you see there is two strategy. According to the angle, there may be provisional with tap. And if you not continue consider the angle, then there is two option: mini crash or decay crash. Hello. And here the performer done the provisional stenting with tap technique. Tap. But the size of the left main is not considered well here, because the formula of the LAD, LCX and left main double and third. So we think that it is around 5, 3 and 3.5, 3.5 LAD, 3 LCX. So the double and 1/3 the equation. So it may be the left main 4.5 to 5. So the initial pot is very important with shorter balloon, but the performer I think didn't well this initial pot. If you the sir mentioned,
is it provisional?
Is it provisional? But he
no, it is not provisional. It is double
operator is first time decided to do the double stent study.
Double stent, I think it should go either for mini crash or decay crash. If this is decay crash, then pot and repot, final pot is mandatory. But in case of mini crash, the final kissing is mandatory. There is not, but here the decay crash, according to the mesh rate, the decay crash result of decay crash is better. Because the shape of the left main in case of mini crash is oval shape.
Okay, thank you. Now we got your point. Recent studies shows that decay crash is superior than any other vibration
because this is circular. Circular and pot is effective here because we should maintain the normal physiology of the artery. The normal physiology of the artery is circular. So decay crash should be or could be the option here.
Okay, thank you.
Thank you.
May we go to the Professor Shahabuddin Talukdar sir. If you have any comment.
Already discussed, but to me, this is the decay crash is the stent of two stent strategy. Decay crash in this bifurcation, distal left bifurcation is the option of choice. At the same time, you have to take the smaller balloon. Stent should be 8 to 10 millimeter greater than that of the length of the from your bifurcation, because you have to do the pot before you recross. That's why you have to take a smaller balloon and should not touch the normal artery. But she has taken longer balloon, and that injured the normal vessel that will produce in future stenosis of the left main. So take home is that you should take shorter balloon to pot and report proximal to the carina.
Thank you, sir. MJ Azam, you have any comment regarding tap or decay crash? As the operator was suitable for tap, that's why he did tap, or anybody can approach for decay crash. MJ Azam.
Thank you, Noram. Thank you. Actually, সুন্দর discussion হয়ে গেছে. Distal left main bifurcation আমরা ট্রিট করব কিনা, এটা কি প্রভিশনাল স্ট্যান্টিং এ যাব নাকি ইলেকটিভ ডাবল স্ট্যান্টিং এ যাব, সেটা আমাকে আগে ফার্স্ট প্ল্যান করতে হবে। ফার্স্ট প্ল্যানের মধ্যে যেটা দেখতে হবে, কতগুলো প্ল্যানিং এর মাঝখানে আমাকে সিদ্ধান্ত নেওয়ার আগে কতগুলো প্যারামিটার আমাকে কনসিডার করতে হবে। একটা হচ্ছে অ্যাঙ্গেল দেখতে হবে, সাইড ব্রাঞ্চ কতটুকু ইম্পর্টেন্ট সেটা দেখতে হবে। কিন্তু এখানে যে নাজমুন নাহার যে চয়েস করেছে 011 সিচুয়েশনে, নাজমুন লাইলা, ওর অ্যাঙ্গেলটা ছিল মোর দেন 70। তো সো আমার মনে হচ্ছে ভেরি পারফেক্ট ডিসিশন ছিল ট্যাপ। আর একটা যে কথাটা এখানে বলার বিষয় যে ট্যাপ, ডিকে ক্রাশ, মিনি ক্রাশ, ইনভার্স কুলর যার যেটা পছন্দ সেটা করাটাই উত্তম, যদি সে এটাতে কমফোর্টেবল থাকে। নতুন করে নিউ ভাবে ফার্স্ট টেকনিক সে অ্যাপ্লাই করার ঠিক হবে না। এটা হলো 1 নম্বর আমার টিপস। 2 নম্বর টিপস হচ্ছে যে যেটাতে আপনি অভ্যস্ত থাকবেন সেটাই আপনি প্র্যাকটিস করবেন, নাম্বার 1। কিন্তু অন দ্য ব্যাকগ্রাউন্ড অফ আপনাকে কি কি লিমিটেশন এবং স্কোপ আছে, যেমন 90 ডিগ্রি যদি হয়, বিগিনাররা শুড স্টার্ট ট্যাপ টেকনিক ফলো করা উচিত। তারপরে যদি আপনি পারেন আস্তে আস্তে নেক্সট প্রসিজার গুলোতে 10-20টা কেস করার পরে আপনি আস্তে আস্তে একটু কমপ্লেক্স বা নিউয়ার টেকনিক আপনি অ্যাডপ্ট করার চেষ্টা করবেন। এটা হচ্ছে আমার জাস্ট টেক হোম মেসেজ।
Thank you, Dr. Azam. We are proceeding to our next case. We have already 3 cases we have left. Now I am, would you please, Dr. Kunat Jina Afrin Khan from United Hospital, would you place your case? Your topic is post-CABG PCI. PCI in a post-CABG case. Dr. Kunat Jina Afrin Khan. Yes, you can see your slide. Go to slideshow mode.
And good evening. Can you hear me?
Yes, it is audible.
Yes, you can proceed.
Yes, we have already heard and seen beautiful, challenging cases, and I'm directly going to present my case. My patient was a post-CABG patient with class 3 chronic stable angina with normal ejection fraction. Here we did the relook angiogram showed native triple vessel disease. And right subvenous venous graft to RCA was patent. But the venous graft to obtuse marginal branch was totally occluded from origin. And the Lima to LED shows no significant disease in this view. The lateral view showed significant narrowing at the graft junction. As the patient was symptomatic with a class 3 stable angina with maximal anti-anginal therapy, the patient needed some plan for revascularization. So we had 2 options in our hand. Either we could go for reduced CABG or PCI to Lima graft and native LCS. What does the guideline say? Guideline says that if the patient is has low risk findings in non-invasive testing, then PCI is better than CABG. This is the awesome RCT and registry showed overall equal mortality which was comparable between reduced CABG and PCI. Here we can see that there is significant difference between the PCI and CABG regarding the symptom-free survival for long term in case in groups of the patients who underwent PCI after CABG, though the survival benefits were similar in both groups. So due to similar outcome and late complications, PCI is preferred over reduced CABG surgery in anatomically suitable vessels. So we preferred the femoral approach due to the extreme tortuosity of the Lima. And we first took the 6 French internal mammary guiding catheter, and BMW wire was negotiated with the help of the microcatheter. We wanted to insert another guide wire to the lesion because we needed better stability, but we could not negotiate the wire. Then we took the support of the balloon, but still it didn't help much. After that, we again took the microcatheter to reinsert the second wire. And after reinserting the wire, it was exchanged with the all-star wire for better support, as all-star gets better support. With some difficulties, we could dilate the lesion with a 2 × 12 millimeter balloon at 14 atmospheric pressure. But after the balloon dilatation, the patient developed a slow flow. So we put loads of intracoronary GTN, and we pre-dilated again. After that, at the check shot, it was assumed that there is a dissection at the junction graft, the graft junction. We removed all the wires out of the coronary bed, and we put more GTNs, and we waited for a few minutes, and then we took another shot. It showed it was actually a concertina. So as we have experienced already that we face difficulty to insert our wires and other tools through this very tortuous graft, we decided to take guide extension catheter. So we wanted to take a 6 French guide extension catheter, so we exchanged our guide catheter to a 7 French. We took 7 French internal memory guide catheter, and we again reintroduced with the same procedure, the 2 BMW where with the help of microcatheter. Then we took the guide extension catheter with the balloon support and with the support of the 2 wires. Finally, we could stent the area with 2.75 into 18 millimeter onyx stent, and it could be successfully deployed. Final shot showed well revascularized lima to LED. Next, we needed to revascularize the native LCX vessel, as we could see the curve of the LCX from at its origin from the left main. So we understood that it would we face a difficulty in both wearing, and we also need more support here. So we wear both the LCX and ramas, and we could proceed the balloon. It was a 15 millimeter balloon. But after balloon dilatation, we failed to pass the stent through the lesion. We could not pass our stent up to the lesion. So the wire from the ramas was withdrawn withdrawn towards the LCS to OM, and we again took our guide extension catheter with the support of the same way with the support of the balloon and the 2 guide wire. And while we were pushing the stent inside the guide extension catheter, we could see that there was no stent. Though we were pushing it, there was no stent, and we didn't understand what went wrong. Where did the stent go? Then we could understand that something bad has happened. So the stent got separated from the balloon while it was passing through the proximal end of the guide extension catheter. Unfortunately, we could retrieve the stent by half dilating the balloon and pulling it safely through the open port. Finally, we took another stent and we passed the stent very gently through the proximal hub of the axilla, and we could successfully place our stent. It was 2.75 into 48 millimeter onyx stent from LCS to OM. And the post stent dilatation was done using 3.5 into 50 millimeter. Excuse me. And final view showed well revascularized LCS. So my take-home message is appropriate hardware is a must before doing any complex lesions, and adequate support is essential to cross-tortuous lesion. And before using the guide extension catheter, we should keep some things in mind that we have to know where to use or where we can use this guide extension catheter, that it cannot be used in vessels less than 2.5 millimeter size. And pressure, if there is any pressure dampening during using this guide extension catheter, we have to remove the guide extension catheter and wait until the pressure comes normal. And the guide extension catheter should not be proceeded more than 150 millimeter from the tip of the guide catheter. The stent may be dislodged from the balloon if we are harsh while pushing the balloon to the proximal shaft of the guide catheter. It is actually the stainless steel part that is connected with the proximal guide part of the guide extension catheter. We have to be very gentle at that part, and I think the guide extension catheter is a very essential tool if we can use it properly into vector translation. So thank you all.
Thank you, thank you, Tonajina, for showing us a nice case, nice complex case PCI. You have shown that 2 native vessel PCI have been done, and also on graft vessel PCI, and there is a stent loss and retrieval. Thank you for your nice presentation. May I hear from our chairperson or panelist? If you have any comment or question, please off your screen share. Tonajina.
Dr. Tunajina.
Sir.
Walaikum salam. Your case is excellent case because of several reasons. Number one, Lima angioplasty. Number two, using of guide extension catheter in Lima. As we know that Lima is very much prone to spasm and dissection. In that vessel, using the guide extension catheter, doing the angioplasty is really a master job, and that has been done very nicely. It is a very tortuous vessel and excellently done. And secondly, the stent dislodgement that is within the guide extension catheter, that is a lucky affairs, as because God has saved us. Otherwise, if it would be lost in the native vessel, then another situation would happen. So second one, God has helped us very much, and both the cases, meaning that both the procedures have excellently done, and there is no question of any alternatives. And you have already told that every time, whenever we do an angioplasty, we shall have a plan A and plan B, particularly for complex cases, not for usual cases, but for complex cases, always plan A, plan B. And your plan A was with simple guide catheter, but that has been not effective, and so your plan B, that is guide extension catheter, which is very much essential, and you have used it and nicely done the procedure. Thank you once again for showing us a beautiful case.
Dr. Nolan, I have a comment.
Yeah, yes, Dr. Pravir Kumar Dash.
Dr. Tunajina, thank you.
Thank you.
Intervention on two sides, sandwiched surgeon. Started with interventionist, then surgeon, then again interventionist. Your case, thank you. You have seen a rare thing, rather uncommon thing. It looks like a silver chain or something like that. Putting the stent from the balloon because of displacement and putting it on the table, and you have shown the thing. Thank you again. The question is, why you didn't approach through left radial route? Can you consider left radial route in cannulating this graft, Lima graft at the beginning? Why you preferred femoral?
We choose femoral.
Not right radial, left radial.
As we anticipated difficulties to pass the our tools toward through the very tortuous vessels of the Lima, that we could see the Lima was very tortuous vessel, and we anticipated that we would face difficulty to negotiate our balloons and gears and stents through this. So we know to even we may have to take 7 friends. So I would think that to combat our any situation in our hand, if we choose the femoral approach, then it would be easier for us to complete.
Oh, thank you. Okay.
Any comment or question from the chairperson or panelist or faculties?
I have just one comment.
Yes, sir. Yes,
that
sir.
after doing such a difficult angioplasty in the Lima, which with a guide extension catheter, because I have myself dissected Lima while doing it, very vulnerable to dissection.
Yes,
why didn't you leave the circumflex on medical management? Because this was it was just a stable angina case. You could vaccinate anti-anginal and leave the circumflex for a later occasion.
And
but
all of
ultimately, this was a fantastic case. Tunajina, congratulations.
Yeah.
Thank you. Kaisar
Excellent,
Nasrullah
yes, sir.
Khan. Kaisar Nasrullah Khan, would you have any comment regarding this excellent case? Dr. Kaisar Nasrullah Khan.
Can you hear? Unmute, please.
Kaisar bhai, unmute, please.
Excellent initiative by the BSCI executive. I really appreciate the whole committee, the President Secretary, and also Nura. It's wonderful. Sir. Yes, the case was mine, my case, and it was a really tough case. I think I've spent 2.5 hours on this. I started with left radial. I think left radial, but it was 6 French left radial. The artery was small. When there is spasm and I need to take the guide extension to push to right femoral. Of course, start can be left for medical therapy, but when you have done the lima and leading starts, let's finish it in one go to save some money. That's but thank you all, and nice to see you all.
I have one comment. May I comment?
Yes, Dr. Ashok Datta, yes.
Yeah. Thank you, Sulanjana. That is a actually excellent case. This is a master case. After predilatation, I have just one query. After predilatation, you remove everything. When you see that concertina or it is dissection or dilation, you remove the wire, you remove the catheter. Yeah.
Yes.
Yeah. I several cases I have faced the same thing. After wiring, even with very floppy wire, when there is transverse vessel, the concertina looks like very tight lesion. In that case, one tips is if you use the microcatheter, that is fine cross actually. If you put the fine cross over the wire and keep the fine cross inside the vessel, remove the wire, fine cross usually take the shape of the artery and it will remove the concertina effects. So sometimes I saw that it is very much effective whether you are confused when you are confused regarding the concertina or real lesion. Otherwise, after predilatation, to remove the wire, sometimes second time rewiring may be difficult. Otherwise, it is a master case actually.
Thank you, Dr. Ashok Datta. If there is no comment, we can proceed to our next case. So our next case from Dr. Aisha Kader. She is from Ibrahim Cardiac Hospital and Research Institute. She will talk on a case of bifurcation stenting in ACS. Another bifurcation stenting, but this scenario is ACS. Let us hear from Aisha.
So can you hear me, sir? Can you hear me?
Yes, loud and clear. Okay.
Please continue.
Thank you. Assalamu alaikum and good evening to the respected panel of experts, teachers, mentors, and colleagues. And thank you to the BSCI for an opportunity to present our case. I'll be presenting a case of bifurcation stenting in acute coronary syndrome, and I would like to acknowledge my mentor, Professor Maksumul Haq, who was the primary operator of this case. So this was a 62-year-old male who presented with chest pain with severe sweating for 2 hours, and his ECG on admission in the emergency room showed an ST depression in V1 to V. Bedside echo showed an ejection fraction of 45%, and as the patient had ongoing chest pain, he was taken to the cath lab. We proceeded for angiography through the right transradial approach using a 5 French TIG catheter. As you can see, the left main has no significant lesion. The circumflex is all right, but there is a significant bifurcation lesion in the LAD at the level of a very large diagonal branch, which is better visualized in this image on your left. This is a Medina 111 lesion. The RCA had a superior takeoff with no significant lesion. So given this anatomy, what should be the PCI strategy? As you can see, it leads a significant side branch, which is pretty much as large as the main branch. So a single stent strategy is probably not the best approach, even though the setting is ACS. So if we were to do an upfront two-stent strategy, which technique should be done? Should it be a main branch first strategy, that is either a tap T-stent or culot, or should it be a side branch first strategy that would be predominantly a DK crush, other cases an inverted main branch stenting? So depending on the bifurcation angle and the risk of losing an important side branch, this is the European Bifurcation Club algorithm, where in cases where there is a major concern regarding the side branch after main branch stenting, one should adopt a side branch first approach, and this should ideally be a DK crush, which is what we proceeded to do. So engaging it with an EBU 3/6 French guide, both the LED as well as the diagonal were wired by Sion Blue guide wires, and the side branch was then pre-dilated with a 210 balloon at 14 atmosphere. So then we took down a 220 balloon into the main branch, kept it at the bifurcation, and then took a 2.25 by 18 millimeter drug-eluting stent, which was passed into the side branch and deployed at 8 atmosphere with a slight 2 to 3 millimeter protrusion into the main branch. Then the wire as well as the stent balloon of the side branch was removed, and the first crush of the DK crush was done with a 0.75 12 millimeter NC balloon kept in the LAD. Wires were then recrossed, and the first kissing balloon inflation was done at 12 atmosphere. So the first crush as well as the first kiss of the double kiss crush has been completed. And this is the picture. We also did a short pot. I don't have that image, and this is the picture after that with a little bit of carino shift. However, we then took the stent into the LAD, which was a 2.538 meter drug-eluting stent, and it was inflated at 14 atmospheres. Even here, the side branch wire is not kept big in order to perform the second crush. So in the DK crush, the second main branch stenting is what constitutes the second crush of the side branch stent. And then a final kissing balloon inflation was done with the 2.7510 in the main branch and 2.59 NC balloon in the side branch at 12 atmosphere. So this is the second or final kissing balloon inflation. This was followed by a final pot of a 2.7510, a short NC balloon in the main branch at 12 atmosphere. And these are the final angiographic pictures with the satisfactory angiographic result. Sorry. So in active two-stent strategy, we decided to go for a DK crush in this case because it is an upfront two-stent strategy that is compatible with the 6 French guide. And also there is less stent distortion. And also there's no risk of losing the side branch, as we see that this was a very significant side branch of a Medina 111 classification. So in conclusion, DK crush is proven to be a superior technique for bifurcation PCI, and it is ideal for transradial approach as it is compatible with the 6 French guide. The important steps are kissing balloon inflation as well as pot at high pressure in order to ensure good angiographic results and clinical outcomes. As such, it is also important to ensure that adequately sized balloons are available on the shelf prior to embarking on a DK crush strategy. And also this is further defined by the recently presented definition 2 trial, where they showed that an upfront two-stent strategy is superior to a provisional approach in case of true complex bifurcation lesions, as was in this case. And last but not least, an upfront two-stent strategy is really appropriate even in an ACS settings, and it should not be hesitated to be done with good operator expertise. Thank you for your attention. I wish you all health and safety, and thank you to the BSCI for this opportunity.
Thank you, Dr. Aisha, for your nice presentation, especially the last part you mentioned, the expertise in DK crush. This will be beneficial, and you have mentioned the recent trial result that DK crush is favorable in bifurcation lesion. Now the floor is open. If our panelists and chairperson of faculties want to comment, just unmute and comment on this case. May I request Professor Abdul Adud Chaudhary, sir, to have a few comments on this case. She shown that in radial root decay crash, definitely is a glamorous case. Unmute, sir. Please unmute. Rubaiyat, Dr. Adnan, you open the option to unmute the panelist. Dr. Adnan? Dr. Adnan, can you hear me? Sir, just unmute, sir. All right.
Aisha has shown something very important. One is that when there is a big side branch and it's a true bifurcation lesion, and upfront twisted strategy should be decided upon earlier. That's very important. The second is, as the recent study she has shown, decay crash is better than others, though it's complicated. But as somebody has already mentioned, it actually depends upon the angle and your preference, your expertise in which strategy to choose. But decay crash is gaining again popularity. And this upfront twisting strategy in the long term, sometimes it's giving better result than provisional stenting. Though provisional stenting is always easy.
Thank you, sir.
Aisha, nice presentation, very nice case.
Thank you, sir. Thank you, my mentor.
Dr. Asha, Dr. Asha Kadir.
Yes, sir.
This is the, thank you for presenting an excellent case. This is the case for double stent strategy is a must. As because the side branch, the lesion in the side branch is more than 5 millimeter from the ostium and that is critical. So we shall have to go for double stent strategy. Second one, the angle is smaller, so we shall have to go for decay crash. That is also all right. Finally, it is in radial route. Radial route with 6 French guide, decay crash is very, very difficult. As because 6 French guide, whenever we do decay crash, then 2 balloons, whenever you use, then both the balloons should be NEW. If the balloons are ox, then it is not possible. So then you will have to change the guide to up to 7 French. And though we can do 7 French by transradial approach, if the vessel is good shape and good caliber. So overall, with the 6 French guide, in transradial approach, the bifurcation stenting, decay crash is an excellent job. Thank you.
Professor Khandekar Shohid Hossain, I'd request you.
Yes, thank you, Aisha Kadir, for a nice presentation. I want to add something here in decay crash technique. These are very important for a good job. In decay crash, in the first class, what should be the balloon size? This is very important. And sometimes this crashing, when we put a stand in a left main to LAD, what should be the size? The size should be the distal reference vessel diameter. But sometimes there is a discrepancy between the size of the distal vessels and the proximal vessels where we want to crush. In that case, the balloon size should be shorter. And the ratio of the balloon and the main vessel is 1:1. Because if we here you use balloon, I think so far I remember the first class balloon was 2.75, and you put a stand in the LED that was 2.5. I think
LED was 2.75, 38.
Okay, that means that is very important thing. What should be the size, especially when we do decay crash in the left main and LCX. In that case, the left main size may be 4 or 4.5. In the LED, that may be 3. And in that situation, what should be the balloon size? This is very crucial because I cannot expand balloon more than 3 because the distal diameter is 3. What should I do in that case? Because if I put here a 3 millimeter diameter stand, it will undercrush the side branch. because at least it needs 4 millimeter diameter stand to crush the stand. In that situation, what we can do, I expect some comment from my seniors.
Hello, Muslim sir. Hello.
Hello.
Hello, Muslim sir.
Abdul sir আছে বলতে হবে Abdul sir.
হ্যাঁ আছি তো এই
Sir, Abdul sir, please
Plural-
comment.
Acha, this is a fantastic case, I will say that, and done by the radial route, and I am sure they are using all the balloon new. In 6-friend guide catheter doing the
Right, sir.
decay crash, there must be new balloon, because if you
Right.
use the old balloon, then it will be difficult. So
Yes.
definitely, as our data, decay crash is claiming that it is better. It is the only established in decay crash trial, nothing in other trials. That's why decay crash is the best always. It is difficult to say. Somebody believes, somebody doesn't believe. But the decay crash 3, 4, and 5 trials show that decay crash is better than the culotte technique, or decay crash is better than the T-tap technique. But if you consider the EBC guideline, they say that still the provisional stenting, single stent strategy is better. If you can do it, 70% solve the problem. T-stent is also a good option. And they have a last study is going on, I think so, the EBC 15 trial. This trial is end of this last year, but it is not published. They compared that the decay crash with the culotte and the tap technique. Then they will come to conclusion that which technique is better. But up to date now, still I am agree with the Aisha that decay crash may be the better, but it is not. Everybody doesn't agree with that. So the message is that whatever technique you are comfortable, if you are comfortable with decay crash, go for decay crash. If you are comfortable with trap technique, go for the trap crash. If you are comfortable with the culotte, you go to culotte. If you are not experienced with the culotte, don't go for culotte. Then it will be disaster. Otherwise, you have to take support. Easiest way is trap technique. Easiest way is trap technique. But if a person, that's why if you want to do the complex distal alignment, you must be expert in the field of the at least some of the technique, provisional technique, tap technique, culotte technique, and decay crash technique. Definitely, decay crash is a good technique and good outcome as comparable decay crash 5 said that. And the question that was raised by the show that distal reference diameter should be taken the size of the stent diameter. Suppose Shoit said that suppose your Letman is 4.5 and your LED distality is landing zone is 3. You will take the 3 millimeter stent, because normally the third generation stent, all the stent can be expanded at least 1.5 millimeter more. So if it is 3, it is 4.5. So you deploy the stent according to the reference diameter and take a small size balloon in the left main and dilate accordingly. If you think the left main is 4, you dilate it 4. With the fast part, if you think that the left main is 4.5, you can take a 4.5. I think so. I'm sure that you are doing like that. Unfortunately, I'm not seeing all this scene, but it is an excellent presentation. And I think Shohid is like to emphasize that we have to take the stent size and balloon size according to difference with the diameter. And already as discussed, and Mir Jamal stressed that we have to take the short size balloon, so that the balloon marker should not be the carina of the bifurcation, should not be at the carina of the bifurcation. Otherwise, there's flat shifting. Excellent presentation, excellent case. I am sure it is only possible by the expert radial operator, because your hospital is doing the radial very, very long time since inception. I congratulate your center. Thank you. Many of them is doing. Ms. Jamal is doing, Apollo is doing, many of the centers is doing the radial. But I might congratulate the Apollo, Ibrahim Cardiac. You are organized, you are doing the radial.
May I?
Thank you very much.
Aisha,
yes,
may I comment?
Yes, sure, sir.
Just to answer to Dr. Khandokar's query. So
right.
Recently, the European guideline, European bifurcation guideline, has added that when you dilate, when you crush, you have to take first the distal diameter balloon compatible with balloon size as according to distal vessel. But also you have to take a second balloon that has been introduced in the recent. You have to take a second shorter balloon for the proximal vessel so that the stent expands properly in the proximal vessel. But the cost goes high. So sometimes what we do, we compromise in between. You take a balloon, say a little bit 0.25 higher than the distal one, and dilate it with nominal pressure. And the same balloon we take proximally and go up to 24, 26 to cut short the cost of the balloon.
Yes.
That's what we're doing. And another thing, to pass two balloon or one balloon and one stent, which is 6 French catheter, through a fixed French catheter, it is sometimes difficult. And there is always worry that the stent may be dislodged. In that situation, we always take the stent first. Stent first, position the stent, and then take the balloon. So we don't have to struggle with the stent. Otherwise, stent may dislodge. That is what we usually do.
Thank you.
Thank you. Thank you.
Thank you, sir. Thank you. On question from participant, you unmute and ask your question.
Dr. Mahbub.
Okay, Dr. Mahbub, ask your question.
হ্যাঁ, আমি ডক্টর মাহবুব রহমান বলছি, বাংলায় বলি, রংপুর থেকে বলছি। এখানে আসলে অ্যাকিউট এমআই খুব এক্সপার্টিস ছাড়া এরকম অ্যাকিউট সিচুয়েশনে, প্রাইমারি পিসিআই সিচুয়েশনে ডিকে কাজ করতে না যাওয়াটাই ভালো। এক্ষেত্রে একটা অপশন আছে, যদি রেডিয়াল অপারেটর হয় তাহলে 6 ফ্রেন্ডস দিয়ে স্টেপ ক্রাশ, মিনি ক্রাশের যার একটা অপশন আছে, স্টেপ ক্রাশ বলি, যাকে সাইড ব্রাঞ্চে স্টেন্ট দিলাম, তারপরে বেলুন আমার থাকলো মেন ভেসেলে, সেটা দিয়ে ক্রাশ করে তারপরে ওখানে স্টেন্ট দিয়ে আমি যে মিনি ক্রাশ যেটা করলাম আর কি। এখানে মিনি ক্রাশ এখানে একটা ভালো অপশন, কারণ কি দুইবার আপনি ক্রস করবেন। ডিকে ক্রাশের ক্ষেত্রে আপনার প্রক্সিমাল স্টেন্ট স্টার্ট দিয়ে আপনাকে ঢুকতে হবে, একবার ঢুকবেন, কিসিং করবেন, পট করবেন, আবার ঢুকবেন, আবার কিসিং করবেন। এই মুহূর্তে এরকম সিচুয়েশনে যদি কোনো কারণে হেমোডাইনামিক ইনস্টেবিলিটি বা আনস্টেবিলিটি এসে যায়, তাহলে সেক্ষেত্রে পুরো জিনিসটা প্যানিক হয়ে যায়।
আচ্ছা মামুন, আমি আপনার কোশ্চেনটা যেটা বুঝতে পারছি, মামুন আপনার কোশ্চেনটা যেটা বুঝতে পারলাম, নুর আলম আপনার কোশ্চেনটা যেটা বুঝতে পারলাম, প্রাইমারি পিসে সেটিং এ ডিকে ক্রাশ না করাটা উত্তম, এটা ওনার কমেন্ট নাকি? নট কোশ্চেন তো না।
এক্সপার্টাইজ থাকলে করা যেতে পারে।
আচ্ছা জাস্ট এ মিনিট, আয়শা তোমার আনসার আগে আমি যাচ্ছি। মামুনকে বলছি, মামুন এসসিএস সেটিং এটা করা হয়েছে, নাম্বার 1। নাম্বার 2, প্রাইমারি পিসে করা যাবে না এমন কোনো গোল্ডেন রুল নাই। ইট ইজ অপারেটর ডিসক্রিপশন। অপারেটর যদি কমফোর্টেবল থাকে, তার মেইন টার্গেট হচ্ছে এস্টাবলিশ দ্য ফ্লো ইন প্রাইমারি পিসে। তুমি কুলোটে করো, তুমি যদি মনে করো ডিকে ক্রাশ করো, তুমি যদি সিঙ্গেল স্টাডিতে যেতে চাও, ডাবল স্টাডিতে যেতে চাও, ইট ডিপেন্ডস অন ইউর স্ট্র্যাটেজি উইথ এভিডেন্স। তোমার মেইন টার্গেট হচ্ছে এস্টাবলিশ দ্য ফ্লো অ্যাজ সুন অ্যাজ পসিবল উইথ মিনিমাম কমপ্লিকেশন। এটা হচ্ছে মেইন টার্গেট। যাই হোক, এটা হচ্ছে যে এই কথাটা আমি এখানে বলতে চাচ্ছি না। আমি যেটা আমাদের যে প্রেজেন্টার যে আয়েশা যে প্রেজেন্ট করছে সেটা বলতে চাচ্ছি এখানে, যে আমরা সাধারণত ডিকে ক্রাশকে প্রেফার করি বিকজ অফ আউটকাম, টার্গেট রিভার্স কোশ্চেন যেহেতু কমফোর্টেবলি বেটার দেন এনি আদার প্রসিডিউর, আমরা এটাকে পছন্দ করছি এবং আমাদের কাছে এভিডেন্স তাই আছে। ডিকে ক্রাশ যে যতগুলি ট্রায়াল আসছে অলরেডি, ডিকে ক্রাশ 4 ট্রায়াল যেগুলো আসছে সবগুলি কমফোর্টেবল। বাট ইউনিক বিউটি ইজ দ্যাট যে আমরা অলওয়েজ লেফট মেইন ইজ সিকিউরড, আমাদের লেফট মেইন যে ভেসেল সেটা সিকিউর থেকে অয়ার সবসময় থাকে। এটা একটা আমাদের এডিশনাল প্লাস পয়েন্ট। কিন্তু যেটা হার্ড রিয়ালিটি প্রবলেম যেটা হচ্ছে রিপ্রসেস।
Interesting case from Dr. Chayan Singha. A lot of discussion will be there. Dr. Chayan Singha from BSMMO, his topic is do or not to do in acute crisis. Do or not to do in acute crisis. Dr. Chayan Singha. Dr. Chayan?
Sir, can you hear me, sir?
Yes.
Yes.
Honorable Chairperson, respected panelists and learned audience, welcome to everybody.
Unmute Chan. Adnan.
Okay, sir, can you hear me, sir?
Yes, loud and clear.
Okay, sir. Honorable respected panelists and learned audience, welcome to everybody in today's virtual session It's my great privilege and honor to present my case in front of such eminent and great cardiologists in our country in the forum of BSCI. First of all, I pay my deep respect and deep feelings to the person who have died in the COVID era, and must appreciate all the presenters who have presented their topic very nicely, and it's a very wonderful discussion indeed. Now I am going to present my case.
Just click and move. Click and move.
Okay. My patient, a 60-year-old gentleman, having the coronary risk factor of diabetes mellitus, hypertension, and smoking, he presented to me with the complaints of ischemic chest pain and sweating for half an hour. On examination, he was anxious, sweaty, blood pressure was low, 90/60 millimeter of mercury. Then immediately we had done a 12B DCG, which shows ST segment elevation in the lead 2, 3 AVF, and ST depression in the AVL, V1, V2, and AVR. So on the background history and ECG finding, we assume that this is a case of ST segment elevated MI inferior. Then promptly we given him loading dose of aspirin, ticagrelor, along with atorvastatin and pantoprazole. Simultaneously, I had counseled the patient regarding the potential benefit and consequence of the early reperfusion therapy, and the patient agreed to take the best available treatment in our country. For that purpose, we taken the patient into the cath lab promptly, and in the angiographic view, we have found that LCX is normal, and OM1 is the principal OM, and OM2 has significant stenosis, but diameter is not so big. Here shows the LED is quite good, and the this view, spider view, reveals that left main and LED and LCX was normal. Then we proceed to right side. Here shows there is a critical stenosis in the osteoproximal part of the PLV, which a large thrombus in situ, and the vessels to some extent ectatic. Here the view shows the large thrombus, critical narrowing, and ectatic part. So what could be the best option here? Should we defer and go for antiplatelet and thrombolytic and retry again, or should we go for mechanical thrombus aspiration? Though the recent guideline tells that the routine use of thrombus aspiration is not recommended, or can we go for intracoronary thrombolytic by microcatheter? As the patient complaining the ongoing chest pain and the hemodynamics was not good, so we proceed for as follows technique. For purpose of primary PCI, at first we engage the RCA through the Judkins 6-French diagnostic guide catheter, and a bolus of infusion in GP2B3A inhibitor was given, and cross the lesion with a round through floppy wire, and very carefully we proceed for thrombosuction. And after thrombosuction, a good amount of clot had come, and this is the result of the thrombosuction, which shows the better visualization of the vessels than past. Then we deployed a 3.5 into 18 millimeter drug-eluting stent, and here shows the mid part is has OS, so we deploy it in the another time with little bit higher pressure. And this is the result after stent deployment, showing the good TIMI3 flow and grade 2 or 3 myocardial blush. And this is the final result, which showing the appreciating result. And this is the hardware we had used. And after the procedure, patient felt a great relief and normal. And the post PCI ECG on the same day it was done, and it shows significant ST resolution occurred. And in the next day, we had done an ECG and echo. ECG shows the almost complete resolution of the ST segment. And currently patient was absolutely symptomless, and his ECG was very nice, normal, and other investigation reveals, echo reveals good. His diabetes is super controlled with metformin and empagliflozin, and other metabolic profile is normal. So my take from this presentation is intracoronary thrombus during STMI is common and it carries a therapeutic challenge, but early intervention in STMI brings a wonderful result, even in high thrombus burden, though mechanical aspiration thrombectomy is not routinely recommended due to risk of stroke or other complication, but judicious use could make the procedure successful, like in this case. Actually, we are passing a very tough time in the COVID era, so hope for the best. We are hoping that good news come. Thank you very much. Thank you for your patience hearing.
Thank you, Chan, for showing us a primary PCI case having large thrombus burden, and you did thrombus aspiration, and finally you did a very good job. Now there are some issues. Yes, sir. Regarding thrombus aspiration, regarding defer procedure.
Thank you, Chayan. Thank you, my respected teacher and colleagues. Good night, good evening. Chayan presented a very good case. There is several issues because nowadays thrombus aspiration is class 3 recommendation, sometimes is guideline shows, but it should be individualized for case to case. Chayan case also shows that there is a huge load of thrombus. I think for this reason he used the thrombosuction. But I think there is another issue for this particular case. There is a very critical stenosis, very critical chronic stenosis of this patient. So I think thrombosuction, it may be possible to remove the critical lesion with appropriate size pre-dilatation balloon. Then I think the thrombus and use intracoronary abeximab or other 2D GP3 inhibitor. It can be possible without thrombosuction, I think, because the last slide also shows there is a critical waste. Still there is a critical waste in the middle part of the stent. So there is a critical lesion. So if we dilate, then I think the thrombus and intracoronary use of thrombolytic inhibitor. So I think thrombus should be removed in the distal part and it's dissolved. So this is the my comment about the Chayan case. Can I comment to another case, one or two?
Sir, yes, you can comment, sir.
My short comment in the Shakib case is very excellent case, but I can remember the osteoaortic lesion is very dangerous, and how to avoid this in the junior or we are also avoid it. The cautious use of guide catheter and all the instrument, all the device which is used for PCI. But think মাকসুমুল্লাহ স্যার বলে গেছে যে একটা শর্ট দেওয়া কিন্তু খুব দরকার, কারণ অ্যাথেরোমেটাস প্লাক না থাকলে হেলদি অস্টিয়াম অফ দ্য রাইট কর্নারি made a dissection with very rough reused balloon or guide catheter is possible. But if you use new without atheromatous plaque or mild lesion, it is very difficult to produce dissection. So we must careful about a very jet, non-selective jet, whether there is any plaque or not. About first case. Second case is myself with even then Nuralam is also there. Yeah, there is a stuck balloon failed to deflate in the stent balloon. If it is pre-dilatation balloon, if it is post-dilatation balloon, there is a question of reuse of spot or like this. But it is stent balloon. We should think there is a technical difficulty, manufactural difficulties there. So what are the options in our hand to salvage this procedure? Number one, ওখানে কিন্তু এই ব্যাপারটা একটু ডিসকাস হয় না যে কি কি অপশন ছিল তার হাতে, যদি সব না আসতো তখন কি করা যেত। সেটা হচ্ছে আমরা শার্পার এন্ড ইউজ করতে পারতাম, sharper end of the PTCA wire can use and puncture the balloon. Number 2 হচ্ছে আমরা hypo solution like normal saline or dextrose saline we can in 20 cc syringe and dilute, push and pull with high pressure. In this case also 20 to 30% success is there. যে আমরা ডাইটা পাতলা করে এবং কোন জায়গায় অ্যাঙ্গুলেশন হয়ে আছে কিনা বেলুন এবং এর জন্য তাহলে একটা হতো। এটা আমরা একটু দেখতে পারতাম, আমরা করতে পারতাম কিনা। টেকনিক্যাল ডিফিকাল্টিটা স্ট্যান্ড বেলুনের ক্ষেত্রে আমাদের মনে রাখতে হবে। আর লেফটম্যান দুটা প্রেজেন্ট করা হয়েছে, লেফটম্যান এবং স্টেন্টিং এর দুটো অ্যাঙ্গেলের জন্য আজম বলেছে অ্যাঙ্গেল শুড বি কনসিডার ফর ট্যাপ। হার্ট ফাউন্ডেশনের যে শায়লা প্রেজেন্ট করছে এটা only tap is appropriate when case angle is more than 70 degree. Or Dr. Professor Azam already mentioned, if it is less than 70 degree, the decay curve would be the choice. And in CABG case, আমি এখানে একটা বলতে চাই যে ক্যাথেটার এক্সটেনশন, যত ক্যাথেটার এক্সটেনশন ইউজ করেছি 150 মিলিমিটার, তারপরে 15 সেন্টিমিটারের বাইরে যাবে না, কিন্তু বলা সোজা, কিন্তু এটা কন্ট্রোল করা কঠিন। এবং এই এক্সটেনশন ক্যাথেটার ইউজ করলেই কিন্তু স্টেন্ট ডিস্টরশন, স্টেন লস এই কেসগুলো বেশি হয়। ফলে আমরা যখন করতে যাব ক্যাথেটার এক্সটেনশন ইউজ করতে যাব তখন কিন্তু আমরা খুব মাথায় রাখবো যে স্টেন্ট যে অ্যাঙ্গেলে নামে, ক্যাথেটার এক্সটেনশন থেকে ওয়ারে নামে, তখন কিন্তু অ্যাকুট অ্যাঙ্গেল হয়। এই সময় কিন্তু স্টেন্ট ডিসলসমেন্ট, স্টেন্ট ডিস্টরশন বেশি হতে পারে, এটা আমরা মনে রাখবো। এবং আমি মনে করি যারা প্রেজেন্ট করেছে সবাই গুড প্রেজেন্টার, এবং আমরা BSCI থেকে আবার উদ্যোগ নেব। আমাদের প্রেসিডেন্ট, ডিনামিক প্রেসিডেন্ট এবং সেক্রেটারি ডিনামিক লিডারশিপে আমরা মনে হয় এটা সিরিজটা চলতেই থাকবে। সবাইকে
থ্যাংক ইউ স্যার।
আমার বক্তব্য শেষ।
থ্যাংক ইউ স্যার। Sir,
can I have a comment, please?
Yes, sir. Yes, Khalid sir. I am just going to you. Just you responded. Thank you, sir.
Chayan, this patient has got a quite sizable PDA, and the angle between PDA and PLV is quite narrow. While we are pulling out the thrombus, some thrombus may stick to the tip of the suction catheter and may dislodge into the another vessel adjacent. Could you have thought about protecting the PDA with another wear?
Exactly,
in
sir.
Sort of case.
But make the procedure simple. We actually done this, but we are careful regarding when the thrombus aspiration was done. We thought that the thrombus can dislodge that area.
And what about your opinion about deferred stenting in cases of in ectatic vessel with a lot of thrombus burden? Actually,
there is some study tells that we can defer by appropriate antiplatelet and thrombolytic, and we can recheck again a couple of days later. Then we can thought about the reprocedure. But in case of primary STMI, if the as soon as possible the perfusion is established, then outcome may be good. For that purpose, the procedure was undertaken.
Can I add a comment?
Yes, sir. Yes, sir.
We always forget that the language that has been used in the guidelines, routine thrombus effectively is class 3 recommendation. The term is routine. So we can always use thrombus aspiration, but we should not be using it routinely. As in this case, Chayan has done a wonderful job. His idea of using the thrombus aspiration in specific cases is very much correct, but we should not routinely use it.
Thank you, sir. One issue is that in primary PCI, pre-dilatation, sometimes it may be difficult, dangerous, but turn the pre-dilatation. If any comment regarding this pre-dilatation in primary PCI?
আমি একটু বলতে চাই, most of the cases in STEMI, significant percentage of cases there is a acute thrombosis in the critical chronic lesion. That means thrombus in chronic lesion. So if there is we can recognize there is a chronic critical lesion, there need to pre-dilate. There is also not এটা রিকমেন্ডেশন নাই, কারণ আমরা যখন বুঝতে পারবো তখন আমি স্ট্যান্ড নিয়ে যাবো কি করে। স্ট্যান্ড সাইজ কিভাবে ঠিক করবো যদি এরকম 99% ব্লক থাকে আফটার ইন্টারকরোনারি থ্রম্বোস ইউজ অর ইন্টারকরোনারি ডাইলেটর ইউজ থ্রম্বোসাকশন, অতএব আমাদের প্রিডাইলেটেশন করতে হবে।
Thank you, sir. Thank you. Thank you, sir.
I like to add. Routine pre-dilatation in primary PCI is not recommended anywhere. We should not routinely pre-dilate, as because most of the cases there is critical lesion. Then we shall do most of the cases pre-dilatation. No, we should not do most of the cases pre-dilatation. We shall have to see the landing zone proximally and distally as far as possible. If I am sure that this is my landing zone, and then I shall do the angioplasty stenting then. And if I do not see the landing zone, then I shall have to go for the second way. What is the second way? Then I can use GP2B 2BA, and if we see that landing zone is there, then we can do. If still there is no landing zone, then and thrombus burden is more, then we can go for thrombus aspiration. And after that thrombus aspiration, we see the landing zone and we can do the stenting. And still if there is no landing zone, then we can pre-dilate in that lesion. And in the in opinion with Professor Amol, that in this statement microthrombi enters the thrombus into the PTA may be lost. That would be a great loss, and there would be a wire also in the PTA, as our one colleague told, and it should be the wire. One wire should be, whenever we do this type of cases and thrombus section, it is better to keep a wire into the other branch like PTA. Thank you.
Another thing,
স্যারের সাথে আমি একটা পয়েন্ট যোগ করতে চাই। নুরুল হক, এখন ওয়াদুদ স্যার যেটা বললো, এটা তো রুটিন আমরা তো আসলে করব না। আমরা যদি করি সেটাকে বলা হবে বেইল আউট থ্রম্বেক্টমি। বেইল আউট থ্রম্বেক্টমি ক্লাস 2A ইন্ডিকেশন। আচ্ছা, এটা 1 নম্বর ইস্যু। 2 নম্বর ইস্যু হচ্ছে দেয়ার ইজ এ গোল্ডেন রুল ইন কেস অফ প্রাইমারি PCI, until and unless proved otherwise, total occlusion থাকবে, occluded vessel থাকবে। First you down the wire, if there is no established, you can see clearly landing zone, Mirjamasa যেটা বলছে, go straight to standing and come back. But you down the wire, but don't any establishment of flow, then you consider 2 points. And the thrombus burden is much more than you expected. If it is suppose proximal RCA থেকে 20 থেকে 30 মিলিমিটার তোমার লেশন মনে হচ্ছে, এরপরে টোটালটা অক্লুশন, যদি মনে হয় যে হিউজ থ্রম্বাস বার্ডেন, তুমি একটা যেতে পারো ডাইরেক্টলি থ্রম্বোসাকশন, তুমি যে করে এসে দেখতে পারো, যদি দেখো যে এস্টাবলিশড হয়েছে, তুমি ল্যান্ডিং জোন পেয়েছে, স্ট্যান্ড করে চলে আসো। অথবা তুমি ড্র্যাগার ইফেক্ট একটা 1.5, 5 to 6 or 8 বেলুন নিয়ে জাস্ট শুধু আয়ের উপর দিয়ে বেলুনটাকে ঢুকায়া জাস্ট বের করে নিয়ে আসলা, তুমি দেখলে ফ্লো এস্টাবলিশড হয়েছে কিনা। ইফ এস্টাবলিশড ল্যান্ডিং জোন, ইউ জাস্ট স্ট্যান্ড, কিছু হলো না, দেন তুমি প্রি ডাইলেট করলে, তারপরে স্ট্যান্টিং করলে, তারপরে তুমি চলে আসলে। কিন্তু তোমাকে স্টেপ বাই স্টেপ, এগুলো হচ্ছে গোল্ডেন রুল। এখন আমাদের যে চয়নের কেসটা ছিল, পিএলবি তো হচ্ছে লম্বা একটা লেশন ছিল, ইনিশিয়ালি ফ্লো ছিল TB2 ছিল। খেয়াল করে দেখো যে TB2 ছিল পিএলবি তে, আমরা কি এখানে স্ট্যান্ডিং করবো কি করবো না, দিট ইজ দ্য কোয়েশ্চেন নাম্বার 1। এখন আমরা যদি করি তাহলে হোয়াট ইজ দ্য চ্যালেঞ্জ? মহসিন স্যার যেটা বলছে, চ্যালেঞ্জ ইজ দেয়ার, পিএলবি তে পিডিএ তে তোমার থ্রম্বাসটা প্রপাগেট করবে। আমার PDA ইজ ভেরি মাচ ইম্পর্টেন্ট বিকজ ইট ইজ এ ভেরি ডিস্টার্বিং এন্ড ভেরি ইরিটেটিং, বিকজ এটা হচ্ছে এলবি তে সাপ্লাই করছে। আমরা কি প্রিকশন গুলো নিব, এটা আমার মনে হয় ডিসকাশনের ইস্যু ছিল এই জয়নের কেসে।
থ্যাংক ইউ খালেদ মহসিন স্যার।
আরেকটা হলো যে আমাদের প্রাইমারি পিসিআই তে পোস্ট ডাইলেটেশন অ্যাভয়েড করা দরকার যদি সম্ভব হয়। স্লো ফ্লো, নো ফ্লো। হ্যাঁ, আর একটা যেটা হচ্ছে সাকশন ক্যাথেটার ইউজ করবো, এটা ইজ গট এ কোয়াইট এ বিগ প্রোফাইল। তো এই জন্য অনেক সময় পিডাইলেটেশন না করে সাকশন ক্যাথেটার অনেক সময় নেওয়া যায় না, অনেক সময় বাধ্য হয়ে আবার মনে হয় যে পিডাইলেটেশন করতে হয়। এটা ইট ইজ কোয়াইট এ বিগ প্রোফাইল ক্যাথেটার, এটা আবার অনেক সময় সমস্যাও করে পিডাইলেটেশন করলে।
I want to make a comment.
স্যার ফজলু স্যার,
আমি একটু বলি।
জি স্যার।
চয়নের কেসটার ব্যাপারে আসলে একটা জিনিস আমাদের দেখতে হবে যে we have considered it is a primary case and we have already done the coronary angiogram getting critical lesion in distally. We have to intervene. Whatever procedure we adopt, we have to intervene as a calculation of primary case. This is my comment.
Thank you, sir. May I have
আচ্ছা নুর আলম, আমি রিগার্ডিং ফার্স্ট কেস আমি একটা কথা বলতেই চাই।
জি জি,
এটা হচ্ছে যে পারফোরেশন, স্যার পারফোরেশন সরি ডিসেকশন যখন আমি ট্রিট করব, আমরা ইউজুয়ালি উই ডু স্ট্যান্টিং দ্য ডিস্টাল ভেসেল ফার্স্ট, বাট when there is osteoproximal perforation, I have to stand first in the proximal segment to seal the osteal perforation, and I have to wait whether it's sealed or not. If it extends, I shall go for surgery. In that case, Sakib did a standing distally fast, and the proximal stand he put in the second step. But I think that the first attempt should be in the osteoproximal segment. Thank you.
Dr. Shohid, Professor Shohid, you are correct, but thing is that if you would implant one stent in the osteoproximal region and you may not cross another stent through this stent, though we can cross, but you may not cross another stent through this stent, as because your lesion is in the middle part, so you should have to treat first whatever you wanted to treat, and then and there you will treat the osteoproximal part. As we know, most of the cases, this type of dissection in osteoproximal part is sealed by stent, and this is the usual technique. And surgery for osteoproximal dissection is very, very rare. And considering that in good hope that we should be able to seal the dissection, and that is why he has done first the distal lesion and then he has done the closing the proximal osteoproximal dissection.
শহীদ ভাই, আপনার যে কোশ্চেনটা, আপনার কোশ্চেনটার মধ্যে একটা জিনিস হচ্ছে, যেটা শহীদ ভাই আপনার যে কোশ্চেনটা ছিল ডিসেকশন হয়েছে ওই জায়গাতে আগে স্ট্যান্ড দেওয়াটা ছিল ম্যান্ডেটরি, এটাই তো আপনি বলতে চাচ্ছিলেন?
না, ডিসেকশন দুই ধরনের। যে অস্টিওপ্রক্সিমাল ডিসেকশনের ট্রিটমেন্টে আমি যেটা দেখছি বইয়ে, সেটা ওরা বলতেছে যে অস্টিওপ্রক্সিমাল ডিসেকশনের স্ট্যান্ডিং করতে হবে ফার্স্ট ইন দ্য প্রক্সিমাল সেগমেন্ট, আর যদি অস্টিয়াম না ধরে, যদি ডিস্টাল ডিসেকশন হয়, তাহলে তুমি তাহলে আমাকে ডিস্টাল এন্ডকে আগে সেট করতে হবে। আর যদি অস্টিয়াম ধরে,
আমি একটু কথা বলি।
হ্যাঁ অশোক দা, আমি একটু বলে দিচ্ছি। ডিসেকশনের যে মেইন রুল, ডিসেকশনের মেইন রুল, আপনি ওখানে ওটাকে ট্যাকেল করতে হবে। কিন্তু এখানে যে কেসটা ছিল, ওইখানে সে তার ইন্টেনশন ছিল, প্রাইমারি ইন্টেনশন ছিল তার ওই জায়গায় ভেসেলে তার চিকিৎসা করতে যে প্রক্সিমালি তার হচ্ছে ডিসেকশন হয়েছে। তো তার প্রাইমারি ডিসিশন ছিল আমি যেহেতু এখানে কমপ্লিকেশনটা আমাকে ট্যাকেল করতেই হবে, তো সো দ্যাট আমি যেহেতু প্রাইমারি স্ট্যান্ড যদি আমি প্রক্সিমালি দিয়ে দেই, কখনো কখনো স্ট্যান্ড স্টার্টের মধ্যে স্ট্যান্ড আটকায় যায়, সেই জন্য সে ডিস্টালে আগে সিকিউর করে এসে তখন তার এটা ট্যাকেল স্ট্র্যাটেজি।
Yes, this is the point. Okay, thank you Arjun bhai.
And extend was
অশোক দেখতে কথা বলতে চান, নুর আলম অশোক দেখতে কথা বলতে চান।
After Adul sir, we are going to Ashok da. After Abdul Adul Chaudhary sir.
একটা খুব ইম্পর্টেন্ট জিনিস হলো এখানে আসলে আমার যে প্রক্সিমাল ডিসেকশন হয়েছে সেদিকে আমরা পুরো ভেসেলকে ক্লোজ করে দিচ্ছি কিনা। যদি ক্লোজ করে দিতে চাই তাহলে কিন্তু আমি দেখতে পাবো, আমি কিছু করতে পারবো না, আমাকে প্রক্সিমালটা করে ফেলতে হবে। কিন্তু প্রক্সিমালটা যদি আমার ওরকম প্রবলেমেটিক না হয়, তাহলে আমি আগে ডিসচার্জটা করে এসে তারপর প্রক্সিমালটা করতে পারবো। আসলে সিচুয়েশনের উপর নির্ভর করে আমাদের ডিসিশন নেওয়া উচিত। যে আমি যদি মনে করি যে আমার প্রক্সিমালটা এখনই না করলে পরে আমার ঝামেলা হবে, আই হ্যাভ টু ডু দ্যাট ফার্স্ট। Anyway, I have to keep the vessel open.
Dr. Ashok Datta.
আমি অজিত স্যার যেটা বললেন, that I was wanting to tell the same thing. এই শহীদ ভাই যেটা বলছেন, that is quite correct. If proximal osteoproximal dissection makes the vessel closed, you have to do the stenting first, then we will go distally. But if you see that is otherwise stable flow is there, just Jamal sir যেটা বললেন, better to do distal stenting then do the proximal. Otherwise for osteoproximal lesion, definitively on to somebody tell maybe 2-3 millimeter you have to put the stent within the outer, otherwise that dissection will not be closed. So in that circumstance, in radial route, guide catheter may not help you sometimes. If it enters into the right coronary, that is other, but sometimes it is difficult to get a alignment. In that case, second stent is very much difficult to push through the first stent. So in these circumstances, what the Sakib did,
distal,
the flow was good, patient was stable.
Yes.
আর এই ধরনের ক্ষেত্রে একটা স্পেশাল বেলুন ইউজ করার দরকার হতো, এটাকে বলে অস্টিয়াল ফ্লাশ বেলুন, যেটা আমাদের কাছে নাই। এটাকে স্টেন্টের অস্টিয়ামটাকে এটা এমন ভাবে ফ্লেয়ার করে যে পরবর্তীতে গাইড বসাতে যাতে কোনো অসুবিধা না হয়। উই ডোন্ট হ্যাভ অস্টিয়াল ফ্লাশ বেলুন, তো পরবর্তীতে গাইড এনগেজ করাটা খুব কঠিন হতে পারে এবং ওর ভিতর দিয়ে স্টেন্ট নেওয়াটা।
থ্যাংক ইউ প্রফেসর মামুনুর রশিদ সিজার। প্রফেসর মামুনুর রশিদ সিজার, ক্যান ইউ হিয়ার মি? প্রফেসর মামুনুর রশিদ সিজার স্যার, প্লিজ আনমিউট স্যার।
আমাকে শোনা যাচ্ছে?
জি স্যার, ক্লিয়ার।
আচ্ছা, না আমি জাস্ট একটু শেয়ার করতে চাই যে আমার এক্সপিরিয়েন্স, এটা আমার সঙ্গে মিট জামাল স্যারও ছিল ওই কেসে, আমরা ওই পেশেন্টটা লস করেছি। অ্যাকচুয়ালি যদি লেফট মেইন অস্টিয়াল ডিসেকশন হয়, আসলে এটা মানে খুবই গ্রেভ সিচুয়েশন। মানে আমি যেটা শহীদ ভাই যেটা বলছে যে যদি লেফট মেইন ডিসেকশন হয় তাহলে কিন্তু জামাল স্যারও ছিলেন আমার সঙ্গে ওঠে, পেশেন্ট কিন্তু আসলে 2-3 মিনিটের মধ্যেই পেশেন্ট মানে মে ডাই, মানে পেশেন্ট। এখন এইখানে একটা যেটা হতে পারে যে একটা জাস্ট মাকসুম স্যার বলেছিলেন যে এখানে মানে ডাই দেওয়াটা আসলে খুব রিস্কি, কিন্তু যদি অল্প একটু ডাই দিয়েও দেখা যায় যে কোনো যে ডিজিটাল ফ্লো যদি না থাকে, তাহলে শহীদ ভাইটাই একমত হওয়াটা বেটার যে হ্যাঁ আগে ফ্লো এস্টাবলিশ করার জন্য লেফট মেইন অস্টিয়ালে আগে স্টেন্টিং দিয়ে নিতে হবে। এখানে শাহরিয়ারের কেসটা একটু ভিন্ন, যেহেতু অলরেডি সে আগে মিড পার্ট অফ দ্য এলইডি নিয়ে মানে স্টেন্টিং করার প্ল্যানে ছিল, অতএব সে জানতো যে ওখানে ডিজিজ আছে, দ্যাটস ওয়াই হি মে থিংকিং সেকেন্ড। তবুও আমার মনে হয় যে লেফট মেইন ডিসেকশন যে একবার জীবনে মানে এক্সপিরিয়েন্স ইয়ে করছে, এখানে কিন্তু সময় দেয় না, একদমই সময় দেয় না। দেখা যায় মানে 2-3 মিনিটের মধ্যে পেশেন্ট একদম পালস, ব্লাড প্রেশার সব ফল করতে থাকে এবং গোয়িং টু বি অ্যারেস্ট। সো শহীদ ভাইয়ের এই পয়েন্টে ঠিক আছে। এখন যদি দেখা যায় যে না ডিজিটাল ফ্লোটা কিছুটা ইস্টাবলিশ আছে, যাচ্ছে, মানে এটা অপারেটরের চয়েসের উপর এবং সিচুয়েশনের উপরে যে সে তখন করবে কিনা। the life of the patient, left main অস্টিয়াল আগে স্টেন্টিং করাটা নেওয়া আমার মনে হয় বেটার যদি ডিজিটাল ফ্লো না থাকে। মির্জান স্যার এখানে আমার মনে হয় যে এই ব্যাপারে ইয়ে করতে পারেন, কারণ ওনার সাথে আমি একটা কেস এরকম আমি করতে যাই, উনি পরে আমার সঙ্গে ছিলেন। আর রিগার্ডিং হচ্ছে যে ইয়ের কেসটা যেটা, না এটা বোধহয় শেষের দিকে, আর কমেন্ট না করাই ভালো মনে হয় সব।
প্রায় 10।
থ্যাংক ইউ স্যার, থ্যাংক ইউ। আবু সেলিম, ডক্টর আবু সেলিম, you want to do a comment? Dr. Abu Salim. Dr. Abu Salim. Abu Salim.
Salim দুইজনই আছেন।
আচ্ছা, ওকে। খন্দকার আসাদুজ্জামান, ডক্টর খন্দকার আসাদুজ্জামান, you are a radial operator and we have seen 2 radial cases. Three.
Thank you. Can you hear me?
Yeah, yes, loud and clear.
Okay. First of all, I like to thank our for arranging such a actually I like to thank regarding the case of the wall. I have seen.
আসাদ ভাই একটু মাইক্রোফোনের কাছে নিয়ে কথা বলেন।
I want to add some points regarding this issue.
Asad could not hear anything.
আমরা শুনতে পাচ্ছি না।
একটু লাউডলি বলেন তাহলেই হবে।
হ্যাঁ, একটু জোরে বলেন।
I need help from the host. Can you unmute?
আসাদকে আনমিউট করতে হবে।
ওকে, কন্টিনিউ। খন্দকার আসাদুজ্জামান, কন্টিনিউ।
Yes. Can you hear me?
Yes.
Okay. I like to add first point regarding the case operated by Dr. Anisul Awal. I have seen he deferred the case due to the radial malformations. So in that case, I have some comments. First of all, you can continue the case because you just cross the lesion by a PTCA wire, and over the wire you can just cross a balloon and the 1:1 size. That is, if your vessel is 4, then you can choose the 4 balloon, and it should be the as much as possible is at least 15 to 20. Just after crossing the balloon across the lesion, you just inflate the balloon and stay for 10 to 15 minutes and then recheck. And most of the cases, 1 or 2 episodes of inflation and deflation, you can overcome this problem and you can complete the same situation. And second comment regarding the case, I have seen in that case that there is a very clear landing zone in presence of huge thrombus burden. If you get any clear-cut landing zone in the distal landing zone, you can avoid the thrombosuction. Only thrombosuction is applicable if you do not found any clearly visualized distal landing zone. So in this case, I have seen that there is a very clear landing zone was present in the distal landing zone. So you should avoid this thrombosuction in these cases, and you can directly acquire the stent to avoid some sorts of inadvertent complications. And all the presenters present their case very quickly and very nicely. So I like to congratulate again all the presenters, and also I like to our teachers who joined their busy schedule in our sessions and enlightened us. So I especially thanks to our comments. Thank you very much.
Thank you, Khondokar Asaduজ্জামান. We have seen Dr. Mominujjaman sir is with us. Lastly, we can get him. Sir, can you hear me, sir? Mominujjaman sir.
Yeah. Yes. I was thoroughly enjoying this discussion.
Oh, that's
I was little bit late. I catch the last 3 cases. Really, I enjoy the discussion with juniors and the seniors regarding do's or don't do's. Really, this sort of discussion makes a lot of things clear to the operator. At least if they made any mistake, he will not do the thing in future. This is actually things the complication. Handling complication is very important, but the operator who is in the lab, he knows how much adrenaline has released. Nobody is there to support it. So this discussion is very good. Few things I don't want to make any comment. Sorry. Sorry, there was a phone call coming.
No, it's okay, sir. Okay.
Sorry. একটু পরে করব। Sorry. Actually, I have got small tips that actually regarding the use of Godzilla that I've seen in Tunajana's case. Always I push the stent on fluoroscopic guide. Especially, we reuse this Godzilla. There is a small friction happened at the junction of the stiffer, that stellate, and the proximal end of the Godzilla. That is the place where every possibility of stent dislodgement. So it's better to negotiate the stent under fluoroscopic guide and not to be too much hurry to cross it. Because if there is any resistance of that, you should not proceed. So there is one tips actually that happen also, although I have not lost any stent, but I have seen there is a little resistance happen at the site of the junction between the Godzilla and the proximal stiffer stellate that you can avoid by using the fluoroscopic guide. Secondly, that the same case, using a stiffer wire within the lima. Actually, this is because of the concertina effect that happened. That shows the no flow phenomena, and it is not that taking extra support or anything. It is because of the wire that created this problem. So even they have used two wire. There is also another problem of precipitating more no flow. So this really tough job. Is preferable to use a very floppy wire, like say BMW wire, and using Godzilla in the left lima. I'm really scared about use of this because that is a lifeline, and the vessel is very spasmodic. So if anything happens, many things can kind of face the complication. So in general, I'm not talking about the individual case. In general, I thoroughly enjoy this program, and at least the juniors, they are doing a very good job, and I always appreciate the juniors who are presenting. Some of them are really much better than me. I'm really proud to see these things. Thank you once again.
Thank you, sir. Thank you, sir, for your valuable comment. May I request Dr. Jillur Rahman? Dr. Jillur Rahman, can you hear me? Dr. Jillur Rahman. May I request Dr. Kajal Kumar Kormukar? Kajal Kumar Kormukar, can you hear me? Dr. Kajal Kumar Kormukar. I think he is not listening. Professor Mahbub Rahman, Professor Mohammad Mahbub Rahman Babu, please, would you like to
Thank you, Nur Alam. First of all, I would like to thank our President Secretary of BSCI for arranging such a good session. I had all the juniors are doing good, and all the topics are time worthy. And thanks again. It's almost 10. I think it should be ended. Thank you.
Thank you. Professor Dr. M.A. Baki sir, can you hear us? You have any comment? Baki sir.
Hello.
জি স্যার
শোনা যাচ্ছে না?
জি স্যার।
হ্যালো, হ্যাঁ শোনা যায়। আমার থ্যাংক ইউ দেওয়ার পালা আর কি। প্রোগ্রাম শেষ। প্রোগ্রামের জন্য আমি অসংখ্য ধন্যবাদ জানাই আমাদের প্রেসিডেন্ট এন্ড সেক্রেটারি বিএসসিআই এবং তোমাকেও এটা পরিচালনা করার জন্য। এবং আমি মনে করি যে এই ধরনের প্রোগ্রাম জুনিয়রদের জন্য তো খুবই হেল্পফুল, এবং আমরা যারা এখনো প্র্যাকটিসিং করতেছি আমাদের জন্য এগুলি অনেকটা হেল্পফুল হয়। এবং আমি আশা করব বিএসসিআই এই ধরনের প্রোগ্রাম কন্টিনিউ করবে। প্রফেসর মীর জামাল এবং প্রফেসর ফজলুর রহমানকে স্পেশালি ধন্যবাদ, এন্ড ধন্যবাদ দিচ্ছি আমাদের যারা প্রেজেন্ট করছেন তাদেরকে।
Dr. Shamsul Alam. Dr. Shamsul Alam, can Dr. Shamsul Alam from Evercare Hospital. Dr. Shamsul Alam. Okay, now we have a participant from Sylhet, Mohammad Azizur Rahman Roman. Can you unmute and take few words?
বাংলাদেশ সোশ্যাল কার্ডিওভাস্কুলার ইন্টারভেনশনকে ধন্যবাদ আপনাদের এত সুন্দর একটি আয়োজনের জন্য। আমাদের প্রেসিডেন্ট মহোদয় এবং সেক্রেটারি মহোদয়কে ধন্যবাদ। আমার দুইটা কোয়ারি ছিল, একটা কোয়ারি যে কতটা সাজেশন স্যার যেটা করছেন একটা শাহরিয়ারের পেশেন্টের, সেক্ষেত্রে আমরা যারা নতুন ইন্টারভেনশনের কাজ করতে চাই বা যারা নতুন কাজ করেন তাদের জন্য ইনিশিয়ালি অস্টিয়াল লিশন যে ডিসেকশন থাকে সেখানে স্ট্যান্ডিং করাটাই মনে হয় আমাদের জন্য, তারা নতুন তাদের জন্য সেফ। যারা এক্সপিরিয়েন্স অপারেটর তাদের জন্য ঠিকই আছে, ওনারা যদি ডিজিটালটা প্রথমে করতে চান পরে কোয়েশ্চেন করেন, সেটা সমস্যা নেই। তো আমার মনে হয় যারা আমাদের মতো নতুন বা যারা কাজ করছেন নতুন নতুন কাজ করে তাদের জন্য অস্টিয়ালটাই আগে, কারণ আমাদের প্রথমেই রোগীর লাইফ সেভ করতে হবে, সেটা একটি। আর দুইটা নম্বর হচ্ছে ডাক্তার প্রাইমারি পিসিআই যেটা ডাক্তার চয়ন করলেন, সেখানে আমরা মনে করি যে আমার যারা নতুন ইন্টারভেনশনিস্ট তাদের জন্য প্রথমে পিএলবিতে যেহেতু লিশন এবং এটা জাস্ট বাইফার্কেশনের সাথেই সেখানে পিডিএতে একটি ওয়ার দেওয়াটা মনে হয় যুক্তিসঙ্গত আমাদের যারা নতুন ইন্টারভেনশন তাদের জন্য, যাতে আমরা যদি কোনো কারণে আমরা ট্রম্বোসাকশনের পরে যদি পিডিএ যদি কোনো কারণে যদি হ্যাম্পার হয় তাদের সাথে সাথে আমরা পিডিএ খাবেন বিগ পিডিএ সেজন্য আমার মনে হয় সেটা আমাদের যারা নতুন তাদের জন্য এটা ভালো হবে। আবারও সবাই আমাদের স্যারদের সবাইকে ধন্যবাদ এরকম সুন্দর একটি অনুষ্ঠান করার জন্য। ভবিষ্যতে আশা করি আমরা আরো বিএসসিআর কাছে আরো ভালো ভালো অনুষ্ঠান পাবো। ধন্যবাদ সবাইকে।
ধন্যবাদ আজিজুর রহমান রোমান। Please share of your screen. May I request, now we are at the end of the session, may I request BSCI Organizing Secretary, Professor Dr. Khandakar Shohid Hossain to say a few concluding remarks. I don't know, on the screen is shared here, please off your screen share.
Hello.
Dr. Adnan, just off the screen share.
Okay, sir. Yes, sir.
Somebody just push the screen share button. So please off your screen share. Please off your screen share.
Professor Baki's screen is sharing.
Baki sir, just press the off screen share.
Try to remove.
Okay, thank you. Professor Dr. Khandakar Shohid Hossain, Organizing Secretary BSCI, would you have please give some concluding remarks?
Thank you, Dr. Nur Alam. I'm very much happy that today's discussion for the progress of intervention cardiology. I think regularly we should arrange such type of discussion, especially if we can arrange a series program like bifurcation session, CTO session, acute coronary syndrome session, and we can only one topic. If we discuss only one topic, so it will be more helpful for the juniors. And if the juniors can the tips and tricks, actually those who are especially in periphery, they are very much this will be very much helpful for them. Thank you all.
Thank you. Now may I request our Scientific Secretary of BSCI, Bangladesh Society of Cardiovascular Intervention, Professor M.G. Azam, to say a few concluding remarks.
রাত তো এখন অনেক হয়ে গেছে। এখন প্রথমে হচ্ছে আমি প্রেসিডেন্ট আমাদের ফজলুর রহমান স্যার এবং আমাদের সেক্রেটারি জেনারেল হচ্ছে মীর জামাল স্যার, আমাদের ট্রেজারার অমল কুমার চৌধুরী, আমাদের সন্তোষ শহীদ হোসেন স্যার সবাই আছেন, এবং আমাদের ভাইস প্রেসিডেন্ট অদূত স্যার, সিজার স্যার, এরা সবাই আছেন, সবাই জানেন যে বিএসসিআই অলরেডি এটা হচ্ছে বিএসসি এর 3rd প্রোগ্রাম। এখন বিএসসিআই কিন্তু বেশ কিছুগুলো সিরিজ প্রোগ্রাম হাতে নিয়েছে। এরপরে যে প্রোগ্রামটা হবে বিএসসি এর শিডিউল প্রোগ্রামগুলো এভরি ফ্রাইডে হওয়ার আমরা শিডিউল করেছি, এবং এরপরে যেটা হবে সেটা হচ্ছে মাস্টার ফ্রাইডে। আমরা যেটা এরপরে যেটা হবে মাস্টার সিডি প্রেজেন্টেশন যেটা হবে। এরপরে হচ্ছে কিছু প্রোগ্রাম আছে আমাদের হাতে, ইন্টারন্যাশনাল ফ্যাকাল্টি যারা আছে, বিশেষ করে আমরা এখন নাম বলছি না, আমরা এখন ডেটটা ঈদের আগে করব না পরে করব। আমরা একটা আইএসআর এবং হচ্ছে স্মল ভেসেল ডিজিজ ইন্টারভেনশন ইন্টারন্যাশনাল ডিজাইন যারা থাকবেন তারা সহ আমরা একটা প্রোগ্রাম করতে যাচ্ছি। আমরা শুধু ওই প্রোগ্রামটাই আমরা বৃহস্পতিবারে করব, আর বাকিগুলো আমাদের প্রোগ্রাম সব শনিবারে হবে। আমাদের নোটিশগুলো সিরিজ আকারে যাবে, আপনারা সবাই সবগুলো সিরিজ আকারে মেইলে পেয়ে যাবেন, নোটিফিকেশনও পাবেন। এবং যারা পার্টিসিপেট করতে চাচ্ছিল, আমাদের অনেক পার্টিসিপেন্ট আমাদেরকে জিজ্ঞেস করছিল আমাকে, স্যার আমরা কি জয়েন করতে পারবো না? আমরা আসলে প্রথমবার এই সিরিজ প্রোগ্রামে অন্যান্য যারা পার্টিসিপেন্ট ওপেন তাদের কেস আমরা নিয়ে আমরা সিলেকশন করে তারপরে তাদেরগুলোকে আমরা প্রেজেন্ট করার ব্যবস্থা করব। আর সামনে আরো এক্সাইটিং প্রোগ্রাম আছে, আপনাদেরকে এটা বলতে পারি। আশা করি আপনারা এগুলো এনজয় করবেন, এবং শুধু এনজয় না, আমরা নিজেরাও শিখবো, আমরা জুনিয়রদের তাদেরকে সুযোগ দিব, আমরা সবাই শিখবো এবং এটা আমাদের কাজে লাগাবো। এই বলে আমার বক্তব্য শেষ করছি। ধন্যবাদ সবাইকে।
Okay, thank you. We are seeing Dr. Kajal Kumar Karmakar in the screen. Kajal Kumar Karmakar, can you hear us? Dr. Kajal Kumar Karmakar, can you hear us? I think Dr. Kajal Kumar Karmakar.
কাজল তো মাস্ক পরে আছে।
ও তো ঘরের বাইরে।
Okay, we now will move our honorable secretary. Kajal Kumar Karmakar,
ওয়েবনার আছে কিন্তু মাস্ক পরা তো আমি শুনতে পাচ্ছি।
আচ্ছা, আবার মিউট হয়ে গেছে, আবার মিউট হয়ে গেছে।
Okay, thank you.
সরি, আমি একটু আসলে জরুরি প্রয়োজনে সাথে আসছি, তবু আলমের মডারেশনে এবং বিএসসিআই অর্গানাইজ খুব সুন্দর অর্গানাইজ হয়েছে, এবং থ্যাংক ইউ ফর অল পার্টিসিপেন্ট, and thanks to all chairperson, and thanks to all panelists and other participants, and thanks to BSCI President and Secretary to organize such a program, and it will be continued. We hope that it will be continued at the COVID situation, and at last I'm thankful to and grateful to Almighty and to depart the soul of our colleagues and moral support our cardiologists and intervention cardiologists. Thanks all.
Thank you, Dr. Kajal Kumar Karmakar. May I request our Secretary General, Professor Mir Jamal sir. Mir Jamal sir, in this situation, sir spent 3 or more hours with us. We are very, very grateful to you, sir, and we are praying Allah that you have full recovery. Mir Jamal sir.
Thank you. Today is the first day after probably 1 month. I am 3 hours in the session. I am grateful to Allah. He has returned me, and I am also grateful to my all colleagues who has supported me in this period, as well as particularly Professor Abdul Wadud Chaudhary, Dr. Momen, and Professor Ali Hossain, Dr. Mahmood, those who have treated me, as well as my colleagues, those who went to this COVID situation. It is not usual to go there. Even then, some of my colleagues, particularly Professor Kajal Kumar Karmakar and my Sakib Masoom, they also went there. I told them, go from here. This is not the other illness that you will come and see me. You pray to God, and I shall be happy. And I am grateful to all that I am with you, at least till now. And I don't know how much I shall alive. Until I shall alive, I shall do the work for the society. And regarding the complication session of Dr. Anisul Awal, I like to say only a few words that any complication in intervention, it seems to be oyster in outside, but pearl in inside. And that is why we are learning from complication. And in that complication, I don't know why you have lost your wire. You should never lose your wire, and this is your final resort. Wire should be in the vessel, then you will be able to proceed. And you could do another PTCA wire along the line of the previous wire, and then remove the previous guide wire, diagnostic wire, and through this PTCA a guide catheter assisted tracking, what I have shown previously, balloon assisted tracking way, and then this guide catheter will also work as healer of the perforation, as well as your procedure will be completed. So in one way you can manage both, and all the cases are very excellent, and presentation is very nice. And for 3 hours, our senior colleagues, our younger colleagues, all of you are participating in this program. We are grateful to you, and we hope that we shall be able to continue this type of program for the development of young interventionalists of my country. This was our commitment to you, to develop our interventionalists. But due to COVID situation, we have become puzzled, and that is why we are now in atrial fibrillation like way, that we are disarrayed, and that is why our program is less, and we are not progressing you so much. For that reason, we are very much sorry to you, but we hope that we shall be able to continue this type of program till COVID continues, and then regular program, so that our younger colleagues become in this field able to do the important works. And we shall have to thank Square Pharma, those who have given us support in this program. Probably MD of Square is with us. My heartfelt thanks to him, and thank to all the participants. Thank you all. Now I am concluding.
Thank you. We are at the end of the program. We'll now go to our president. Before that, I want to comment about just we started. We'll continue.